A very good evening to everyone, and it's a pleasure to be here amongst so many friends, and a pleasure to be here in a meeting that has had such a splendid response right from the beginning. There's several very nice things about the meeting today, and the first is that it makes me feel even more at home in the environments of Pune and the surrounding cities and municipalities. I have always felt at home here because I've been visiting this area for the last 60 odd years, and it was fantastic to always be welcomed with fabulous weather and fabulous food. But now we have an opportunity to be welcomed with fabulous academics as well. And so when a lot of you got together and said, let's start a chapter here, I said, wow, this is absolutely fantastic. And so we all put our nose to the grindstone and said, okay, let's go right ahead. And it's really like a homecoming for me, and I'm sure everyone else at the Society of Field Medicine feels like this. And I'd now like to hand over to our president, Dr. T.L. Praveen, to initiate the inauguration ceremony. You have to unmute, Praveen. We haven't got you unmuted. Now you can unmute. Yes, of course.
Okay.
Yes. Yeah.
Okay. Thank you, Ashok, and thank you, everyone. And it's wonderful that we have started this unit at Pune, because we were missing you all. And we know that there is a lot of academics going on in Pune and then surrounding areas, and there are so many great academicians in Pune. And we would like to definitely share their knowledge and percolate it to the various parts of the country. And this is one of the best opportunities that we thought we would have, and start off with this unit of SFM at Pune chapter, so that we can have a lot of academic activity as well as CME programs, so that we can get together and try to percolate all aspects of fetal medicine. With this, I think we all will be very happy to start off with the Pune chapter. And I think Santosh will take over and then tell us about the plans. Santosh?
Yeah, thank you, sir.
Yeah.
Thanks a lot, Dr. Khurana sir and Dr. Praveen sir, for these kind words. Good evening, dear friends and respected seniors. It is indeed a proud moment for all of us today. A long cherished dream of having our own chapter, the Pune chapter for the Society of Fetal Medicine, has been realized today. Now, fetal medicine is relatively a young player in the field, and we must thank all the stalwarts of SFM who have worked very hard to make this field better and better and accessible to all of us. The idea of having a separate chapter for such a vibrant and dynamic city like Pune was felt for a long time. I used to discuss it with my friends that we should have a chapter of our own many times. And then when Dr. Bimal sir suggested that why don't you form a chapter which will have Pune as well as the surrounding areas, we all jumped at the opportunity and decided to start our own chapter. The Greater Pune chapter has incorporated almost all the areas in the area, including the Pune city proper, right from Baramati to Lonavala, right from Chakan to Pod. So it's a huge area, and a great pool of talent is there in it, as Praveen sir said. An important factor in the success of SFM that I have realized is the great dedication to academics. The organization, the society works only for academics. All of us who attended many society meetings, CMEs and programs have realized that the emphasis is on pure unadulterated academics. There is no pomp, there is no show, there is no fanfare, just great, awesome lectures, cases and discussions and so on. And that is a very inspiring thing for youngsters and those who really want to go ahead in the field of fetal medicine. Dr. Kindre sir yesterday said very nicely that doesn't matter who is behind the machine, maybe a radiologist or obstetrician or fetal medicine specialist. The idea is that person should be a fetal medicine person or a fetal clinician, was his words. And it has really touched a nerve that we must look at the fetus as a whole, and our care should be dedicated in such a way that the fetus benefits. Instead of fighting who will do what, it is better if we come together and evolve. And I'm sure that with all the specialties coming together, the knowledge, the learning will be at an awesome, great level. And I'm sure within a few years or so, you will see a difference in the way that we practice fetal medicine, fetal imaging, especially. Now, I'm very fortunate to be the first president of such a great chapter. And I myself am a radiologist who is practicing for the last 20 years. And my special interests are in fetal medicine. I'm fortunate to have Dr. Gurulaj Lachand sir as our vice president. Though he is a senior teacher, he has very kindly consented to be our vice president. He is also a very senior radiologist with special interest in fetal medicine. He is a consultant at Jahangir Hospital and has his own practice as well. We have Dr. Chinmay Umarji, a very young and dynamic secretary, and he is a gynecologist obstetrician with special training in fetal medicine and has one of the best fetal medicine practices in Pune region at Baner. Then we have Dr. Asha Zakarias, who is a radiologist practicing for the last 15 years or so at Bhosri with special interest in fetal medicine as our treasurer. And we have Dr. Supriya Gadekar, who is a consultant fetal medicine at KEM Hospital and also has her own practice in Pune. She is our joint secretary. Now we have two great patrons amongst us who need no introduction. Dr. Sanjay Gupta sir is a doyen in the field of obstetric gynecology. He is an international figure in this and a great persona. And Dr. Arun Kindre sir, who is one of the pioneers of ultrasound in India. I'm very fortunate to be one of its earliest students. Sir was my guide for my MD, and sir is also an international figure in all this. We have an excellent team of executive council members. We have Dr. Girija Wagh madam, Dr. Suhas Otiv sir, Dr. S.T. Ambardekar sir, Dr. Rajesh Kuber sir, Dr. Aparna Kulkarni madam. And I think with such a great team, and Dr. Priscilla Joshi madam. So with such a great team to guide us, I'm sure this chapter will go great lengths. And I want to promise you all, sirs, that Greater Pune chapter of Society of Fetal Medicine will be a feather in the cap of Society of Fetal Medicine. Thanks a lot again, sir, for giving us this opportunity. Thank you very much. Now I request Dr. Kindre sir to say a few words.
Yeah.
Hi, everybody. Good evening to you all. It's nice to see so many members getting interested in the area of fetal medicine. And if you all remember, the Pune radiologists, if you go back to the year 2015-16, there was very scant respect for fetal medicine in this city, and there was more of resistance. I'm glad that things have now changed, and I think they have realized what is the need of the day. Secondly, I just want to give a couple of messages. When you become a fetal medicine specialist, a new fetal medicine specialist entering the private practice, you want to make your presence felt. And in that bargain, you tend to order more and unnecessary investigations. You must know what is the right time to order the right investigation. And lastly, a message to seniors and my senior colleagues. I'm sure the seniors are also my junior colleagues now. Remember that there is great talent in the city, and I see so many youngsters and young radiologists who are doing excellent work. The message for the seniors is that they must leave their ego and respect the knowledge, and don't ever hesitate in taking the help of your juniors who can be of help to you in case of need. Dr. Aparna Kulkarni, Dr. Meena Nagarwa have been working with me for years, and their close association has really paid rich dividends to me. I can admit that. So respect the knowledge and disregard the seniority. That's my message, and enjoy the rest of the evening and the meeting.
Thanks a lot, sir. May I request Dr. Gupta sir to say a few words?
Yes, it's a great privilege to be here, Santosh and Dr. Ashok. And I remember the very first day when Dr. Kindre had come from Middle East in 1981 and come with the Aloka machine, and that was the first time I actually came across the ultrasound. And it was such an exciting event at that time, that we actually get to see the baby inside the womb and all that. And from there, see where we have come. This particular branch has developed leaps and bounds, and with obstetricians and ultrasonology is coming together in the additional new sub-specialty of fetal medicine. I think now we are going to achieve more and more things. So it's really an exciting time now. And as Dr. Kimre said, I think we all have to recognize the knowledge is increasing by leaps and bounds, and we have to be together and learn together and work together in this particular branch. I'm right now simultaneously on our International FIGO Council meeting, so I'll be missing out some part of the conference, but I'll try to keep on joining.
Yeah, but it is indeed a pleasure to have such great names already associated with our new academic venture. Yes, Dr. Sanjay Gupta, we missed your last sentence. You have to let us know that last sentence. We missed your connectivity for your closing remark. I saw him briefly. Dr. Sanjay Gupta, we missed your last remark because of poor connectivity. I think we're not unable to connect there, so we go right ahead. It is truly a pleasure to be a part of this inaugural event. And like I said, through wonderful friends, Dr. Gupta and me worked together on the FOXI Medical Legal Committee several decades ago. And that's the first time we realized that we actually needed a medical legal committee. We had no idea that things would evolve so much someday. And Dr. Kimre and me have known each other since we met in the very early 80s when we had both gone for training to Denmark. I was asking for directions because I could never handle anything without asking a lot. And I think that's at a good pace in our lives, that it's important to realize that you do things the correct way, and importantly, that you ask when you need to. We've got that message already this evening, and let's go right ahead now and have our three panel discussions. The plan for this evening is that there will be a so-called young presenter, and then with that, we will then move on to discuss relevant portions so that we can learn how to handle a case when we have to actually handle one in real life. And we have an excellent name that we have for our meeting today. It's the long story of the short femur. And so we're going to take up scenarios one by one. I have the privilege of moderating the first scenario, and I take this chance to invite Varun Thakur to present this case. Varun, as you know, has training with Dr. Adi in Bangalore, and now is a practitioner of fetal medicine in his own right. I would request him to share his presentation, and then we will go on to the panel discussion after that. Varun, could you open your presentation, please?
Yes, sir.
Excellent. We can see your full screen now.
Yeah, am I audible, sir?
Yes, absolutely.
Okay. So, good evening, everyone. At the outset, I'd like to thank Dr. Khurana, sir, Dr. Sabni, sir, Dr. Chinmay, sir, Dr. TLM Praveen, sir, Dr. Sahani, sir, and Dr. Mohit Shah, sir, for giving me this opportunity to present a case on this wonderful platform that is Society of Fetal Medicine. Myself, Dr. Varun Ashok Thakur, I've done my MD radio diagnosis in KM Hospital, Mumbai, and I've done my fellowship in fetal medicine under Dr. Adinarayan Makam sir in Bangalore. Currently, I'm working as a consultant in Sri Mauli Diagnostic Services, Moshi, Pune. We know today's theme, that is long story of the short femur. So what exactly is a short femur? Short femur can be defined as the femur diaphyseal length, which is the FL, less than 2 standard deviations or less than the 5th centile. What are the causes? It can be seen in aneuploidies like Down syndrome. It can be associated with various skeletal dysplasias. It can also be seen in fetal growth restriction. And if everything is normal, if it is isolated, in vast majority of the times, it can be constitutional, particularly so in our country. So let's discuss this case. We had this case while I was doing my training under Dr. Adi sir. We had a patient, she was 34 years old, third gravida, she had one living issue, spontaneously conceived, had a previous normal vaginal delivery, was referred to us for a second opinion at 20 weeks for short femur. NT scan and double marker were not done. And this is the finding. We can see that the femur length is 25.6 mm, which roughly corresponds to 17 weeks, 5 days. And that is less than the first centile for a gestation of 20 weeks. But is this really a short femur? This could very well be wrong dates as well. But then the patient was certain about her LMP, and she said that her periods are very regular. And we did the biometry, and all the biometry parameters were corresponding to her gestational age. So what do we do next? When we have one finding, we should look for more findings. In this case, we had this finding. So what we have actually done here is we have reduced the gain and we have put off the harmonics so that this finding is very well documented. We can clearly see that the bowel is echogenic and it is as echogenic as the bone. So now we have two findings, a short femur and an echogenic bowel. What do we do next? We completed the biometry. We can see that the BPD, the HC, the AC is all normal. Only the femur length is less than the first centile. Also, other long bones like humerus, tibia, fibula, radius, ulna, everything else was normal. The estimated fetal weight was normal, and rest of all the other parameters were normal. So we are left with two things, that is a short femur and echogenic bowel. Also, the uterine artery Doppler was normal. So what do we do next? We will do a risk calculation. The age risk is 1 in 502 because she's 34 years old. So her risk is 1 in 502. And for second trimester, use the soft marker risk assessment calculator, beautifully given in this meta-analysis of second trimesters by Maria Agathoklios from the Kypros Nicolaides group. Now, this article is freely available on the internet. It also has an Excel spreadsheet within it. This spreadsheet looks like this. It's a screenshot of that spreadsheet. It has got 8 soft markers. Each soft marker has a drop-down menu. If the soft marker is present, we have to write present. If it is absent, we have to say it is absent. In our case, we had short femur and echogenic bowel. So the positive likelihood ratio of short femur is 3.7 and the positive likelihood ratio of echogenic bowel is 11.4. So to get the combined likelihood ratio, what we have to do is we have to multiply the positive likelihood ratios of the soft markers that are present by the negative likelihood ratios of the markers that are absent to get the final combined likelihood ratio. I'll reiterate, what we have to do is we have to multiply the positive likelihood ratio of the soft markers that are present by the negative likelihood ratios of the markers that are absent to get a combined likelihood ratio. So we've got this number 7.69. So what is the final risk? Final risk is the background risk by likelihood ratio. The background risk was 502 because she has not done any previous screening. So her background risk is her age risk, which is 502. We divide 502 by 7.69 and we get this number 65. And that means her final risk is 1 in 65. So we explained it to her that in her situation, 65 women, of the 65 women, one will have a child who is trisomy 21 and 64 of them will be normal. After counseling and after her consent, did this procedure, which is amniocentesis. We aspirated 20 ml of fluid and we sent it for further testing. Within a span of 3 to 5 days, we got this report of fish. It shows that there are 3 red dots indicating that this is trisomy 21. The other blue and green dots indicate those are normal chromosome 18 and 13. And this finding was later on confirmed on the karyotype. You can clearly see that at number 21, there are 3 chromosomes indicating this is trisomy 21, meaning Down syndrome. So moral of the story is, although our case was a T21 patient, not all short femurs are trisomy 21. If isolated, if everything else is normal, vast majority of them can be constitutional. In a recent article published in the Fetal Diagnosis and Therapy, the article by Dr. Ventura, he says that if there is a short femur, it can also be associated with non-fetal adverse perinatal outcomes like preeclampsia. And if we combine this short femur with biochemistry, particularly with low PAPA, it can give us a better idea about these things. Second thing is, if we get one finding, we should look for more. I'll just tell a small anecdote during my residency. Our previous HOD, Dr. Ravi Ramakantan sir, who is also fondly known as Dr. RR sir, he used to tell us that if we get one finding on a chest X-ray, we should put our palm on that finding. We should hide that finding and we should look for more findings. So that if we find another finding, we can add 2 + 2 and make it 4 and come to the conclusion. The third thing is, we should follow the second trimester soft marker risk calculator, which I just showed. It is easy, it is freely available, and it can help us standardize all the things in the second trimester. Whatever said, the best available screening test today is the first trimester combined screening, that is the NT scan and double marker. And to quote Professor Nyberg, I would say this: may all your femurs be long. To conclude, I'd like to thank my friends, Dr. Purvi, Dr. Ashwini ma'am, Dr. Smita, who helped me make this presentation, and of course, one and only Dr. Adinara and Makam sir, without whom this presentation would not have been possible for me. And to the audience, I'd like to say, break a leg, but not literally. Thank you so much for your patient hearing.
Thank you. Thank you, Varun. That was a nice, crisp presentation. And we move on to the panel. For the panel, I have put up the questions so that we can have it easier, and I'll go on to my slide share. We will, of course, be discussing the same thing several times over today, but we will introduce different concepts with each one of the panels. I have a very illustrious panel with me today. We have Dr. Aparna Kulkarni, who is a very well-known name in fetal medicine, not only locally in Pune, but also all over the country. We have Dr. Archana Kadam, who has an excellent background in developmental aspects of the pediatric patients. We have Dr. Guru Raj Lachim, who's already been introduced already, one of the finest teachers of radiology. We have Dr. Prakash Gambhir, who is a great name, very well known, not only in Pune, but again, all over the country. And we know from the way people in Delhi also believe that samples should go to evaluation, that's speaking wonders. First question is for our presenter, and the first question goes out to Varun again. Varun, when we talk about a short femur, you mentioned about 2 as a cutoff figure. And in the literature, we've had dozens and dozens of these things coming up every now and then. Which one should we reject? Which one should we accept? And is there something? Could you briefly answer this for us?
So previously they used to say that the measured femur length of less than 0.91 moms for the BPD, they used to use that as the cutoff. These days in the recent literature, all the articles, they say that the femur length of less than 5th centile can be used as a cutoff for short femur.
And so basically, we should use a figure that we use again and again and a figure that's used everywhere. Thanks for that very straightforward answer. Next question is for Dr. Gururaj. Any additional inputs on defining a short femur? And the second part of the question on the morphology of the individual bones, how would that help us to narrow down the differential diagnosis in a case of short femur? Dr. Gururaj, please, if you could unmute yourself, and then I'd be happy to hear your answer to this.
Sure.
Yeah.
Okay. Am I audible now?
Yes.
Okay. So basically, Varun has covered most of it already. Additional inputs on defining a short femur, like basically we have to check all. What I would add is check all the bones. Once you see abnormal femur length, you must check all the bones, each and every bone individually. That is one part. Number two is additional, as he's already covered it, additional abnormalities. Like say humerus is also very important bone. So you must see both the humors, whether it is individual or whether all the bones are involved. That is most important. And associated anomalies like pilotosis, hyperechoic bowel, which is already covered, choroidectosis. So if you see one, the risk is less. If you see multiple, naturally the risk goes up. So you have to find out even the minute possible soft markers. So that is one point. Number two, bone morphology. So basically look at the texture of the bone, look at the shape of the bone, look at the density of the bone. So that adds. Supposing you see a fracture, small, the one probably, a femur is short and you're seeing a fracture that could, entirely go to OGI or something. So you should look into that. If you see the texture of the bone, if you see bowing of the bones, then probably, we might be dealing in, say, some form of dwarfism. So you have to.
Thank you. We'll come back more to the associated findings in a few minutes. And we now have a request that we did hear how beautifully we can actually calculate these risk factors. But I'd like Dr. Aparna to repeat for us on this method of calculation. And are there any other methods that we can use apart from this straightforward calculation?
Yeah, thank you, sir. So Varun has very nicely explained in his crisp presentation about the risk calculation for trisomy 21. So repeating it again, second trimester anomaly scan, we look for 9 soft markers in the baby. Among these 9, the strongest ones are hypoplastic or absent nasal bone, followed by ventriculomegaly, ARSA, that is aberrant origin of right subclavian artery, nuchal fold thickness, echogenic intracardiac focus, renal palectasis, short humerus, short femur, and echogenic bowel. Now, what we normally do is look for, some of these markers are very weak and they wouldn't change the background risk of aneuploidy, while the 4 of these markers, nasal bone, nuchal fold thickness, ARSA, and ventriculomegaly are supposed to be stronger markers because they will change the background risk of aneuploidy. So when we see one marker, of course, we have to look for other markers. Now, every marker will have either a positive likelihood ratio if the marker is present. A marker will have a negative likelihood ratio if the marker is absent. So if we see one marker, then take the positive likelihood ratio of that marker. If other markers are absent, then we have to multiply the negative likelihood ratio of the absent markers, and we'll get a combined likelihood ratio. And depending upon the a priori risk of the mother, if the mother has had no screening, then her age risk becomes the a priori risk. So you divide that risk by the calculated likelihood ratio and see if it is high or low. If the mother has had previous screening tests, then the post-screening risk becomes her a priori risk, and that risk should be used to recalculate the risk of trisomy 21 based on the combined likelihood ratio that we have calculated.
Thank you. And what about ready-made calculators? What has been your experience with those? Instead of sitting and working each one of these out, FMF has one in case you pass some tests.
Yeah.
And perinatology has one. Barcelona has one. Any one of these easier than the others?
But honestly speaking, I don't use these available calculators, because once I see the baby, if there are more than 2 markers, the risk is going to be high anyway, and the patient is counseled accordingly. If there is an isolated weaker marker, such as just isolated short femur or isolated renal pylectasis, the background risk is not going to change. So accordingly, we normally counsel the patient. I do not use ready-made available calculators.
Thank you. We have a choice here. Now, Dr. Gururaj has already introduced beautifully the concept of looking for all the associated findings. Varun, in your checklist, what is this? What all would you look for? I know we're going to discuss this again and again this evening, but could you give me just a brief checklist?
Yes, sir. Once we have an isolated short femur, we should obviously, as Gururaj sir said, we should look the contralateral femur and the other long bones to see whether all of them are corresponding to the gestational age or not. Then from head to toe, we should see the skull shape, the nasal profile, the chest circumference, the abdominal circumference, and some ratios like the femur foot ratio, the FL by AC ratio, and also the clavicles and scapula. And lastly, the Dopplers to rule out FGR.
And in this list of Dopplers, would you just stick to uterine artery, or would you like to do the others as well?
During the mid-trimester anomaly scan, we routinely do the uterine artery, sir.
Yes. And then we could take it on from there.
Yes.
Dr. Gururaj, any further additions to this checklist?
Not really. She's already covered everything. So basically, I would say you try to see even the smallest soft markers, like a choroid plexus cyst or something. And if there are multiple of them, then definitely that adds to risk.
And what if we find one of those frank anomalies that we might not have missed in the first trimester screen, like if we find an AVSD or
your slides are not moving.
Would we then move on to this sort of a thing?
Okay. Absolutely. If you have a major,
structural abnormality.
This is for Varun?
No, for you as well. Yes.
Okay. Yeah. Okay. Fine. If naturally, I mean, the main idea is to look for any even major anomaly that is a very strong marker, and then naturally the patient will go for a karyotyping. I believe if there is omphalocele, if there is any AVSD or something diagnosed, maybe we actually investigate at the earliest stage rather than waiting for a late scan and finding out additional anomalies.
And Varun, if you find, say, in association with a ventriculomegaly, then would you use a much larger list?
Yes, sir. If there are other soft markers, then obviously the risk will increase. Ventriculomegaly is a very, very strong marker.
And so in that, would you look for all the other infections and then you pull out?
Yes, sir. Then if there is a ventriculomegaly, then I'd obviously do an extended neurosonogram to look for other CNS anomalies also.
And in terms of observations on the placenta and the volume of the placenta and things like that, would you routinely like to measure those, or do you prefer to use a subjective evaluation?
Generally subjective, sir.
Wonderful. So that's the way we build up the diagnostic possibilities. And the next question then is from genetics. In this scenario, Dr. Prakash Gambhir, what genetic testing would you suggest? QFPCR, FISH, conventional karyotype, CMA, FGFR3, a gene panel, or should we jump to whole exome sequence, or should we decide sequentially?
Actually, in this case, what Dr. Varun has already told us the diagnosis with the FISH test. But if I don't have the diagnosis, like Dr. Varun has also said, if there is one finding, we should look for many findings and we should prepare a list of differential diagnosis. So here, actually, we have a case of 34-year-old woman who has one normal child, then one pregnancy loss and the present pregnancy. Important factor here is that she is 34 years old, as well as she has the risk of aneuploidies of 1 in 65. So in this particular situation, I just look at which soft markers are there. So these soft markers are short femur and echogenic bowel. So does this combination tell us something apart from aneuploidy that I will think of? So first of all, let us go about the aneuploidy things. So aneuploidy, for a 34-year-old woman, we already counseled her that she is likely to have a baby with chromosomal abnormality. So we should have a rapid aneuploidy testing by means of either QA-PCR or FISH test. So the result will be available within 24 to 48 hours, and we should allay these fears. As well as we have one history of one pregnancy loss. So we just should not stop it there, because it may be something other thing than this just number abnormalities. So for this particular thing, I will suggest for this amniocentesis sample to be also processed for microarray. Why I'm saying microarray? Because microarray is the best thing that is possible to look for the imbalanced karyotypes. So it is 1,000 times more powerful than a karyotypes. So instead of all karyotypes, especially if we want to look for chromosomal imbalance and to detect the submicroscopic abnormalities, we should go in for microarray. So for this particular case, again, I said that microarray will confirm the diagnosis of the aneuploidy, whether it is absent or present, as well as it will detect the chromosomal submicroscopic aberrations also if they are there, especially with the view of the first trimester loss that this lady may be having. Third thing, that whether FGFR testing should be there. Now, as Dr. Lachan has said, the bone morphology is normal, as well as achondroplasia, we don't expect it to be manifesting with short femur at this particular time of pregnancy. So I will not advise this particular testing, but I will definitely like to follow up this pregnancy, whether it is she's developing something in say late second trimester or something. So for skeletal dysplasia, if it is obvious, then we should go in for a panel. Either it can be a focused panel for skeletal dysplasias only, or if we don't know diagnosis, we are not sure of it, we can also go in for whole exome sequencing. So this is how I will approach this particular case. One thing which I have not said here is likely, because Dr. Varun has also said that growth retardation is likely for these babies, and the odds ratio is definitely more for these babies if they have short femurs, if nothing else is present. Also, I would like to mention here that this combination can be present in case of an intrauterine infection, that is growth retardation along with echogenic bowel. So if the aneuploidy testing or the chromosomal aberrations are not showing anything, I'll definitely like to test for torch PCR in this particular pregnancy.
Excellent. And would you like to include everything in the torch group, or would you just confine it to say cytomegalovirus or rubella and things like that?
Yeah, it should be, toxoplasma should be there, rubella, cytomegalovirus obviously should be there.
Mm-hmm. And we heard a lot about things like storage of DNA. Would that have any role in this situation? Should we just keep it, or should we just say no? Or is it something that happens automatically when we have a sample that is being processed, that we get DNA anyway and that can be stored?
Yeah, basically we can have DNA storage also. Plus one thing I forgot to mention here, whenever we are going for this microarray testing or exome testing,
yes,
also remember to send the maternal sample, because we should check for the maternal cell contamination, which we cannot make out by the DNA methods. We can make it out on the amniotic fluid fish or karyotyping, but just to ensure that the fetal sample is only there, we should check for maternal serum contamination, maternal cell contamination by the maternal DNA STR and fetal DNA STR's comparison.
Thank you. Thank you very much for that absolutely crisp input for all of this. And the next question, of course, is Dr. Panna, the pre-test counseling.
Okay, sir. Just one query I have. When you say is the pre-test counseling, is it after I've seen the patient with the short femur and echogenic bowel, or before I start scanning the patient?
No. When you made this observation,
yeah,
and then we want to move on to the next step, and before an invasive procedure, how do you approach the whole thing?
Okay. So pre-test counseling, of course, I'll explain the patient what the findings are. The most important thing the patient needs to understand, or I'll tell the patient, is we haven't proven that there is a problem. We are only suspecting some issues with the baby, and we need to do certain investigation to find out what the issue is. With short femur, as Varun had already said, I would say to the patient, it could be a growth issue with the baby, or it could be constitutional depending upon parental height, or even if a grandmother or a grandfather is shorter, sometimes we can have a constitutional short femur in the grandchild. Or Down syndrome as an aneuploidy could be a issue, or infection because there is associated echogenic bowel. With echogenic bowel, it is also a marker of structural bowel abnormality or infection or aneuploidy or growth restriction, and therefore she is going to need serial scans. But the first step would be to rule out chromosome abnormality, for which amniocentesis is available. And in amniocentesis, as Dr. Gambhir sir said, we would look for infection with torch PCR as well. So we have to manage the pregnancy stepwise. Just one test is not going to give us an answer. And once amniocentesis shows a normal report, then the patient is going to need serial sonography to assess what's happening with the bowel, whether the echogenicity is resolving, or whether baby is showing some other bowel structural abnormality which will evolve in the third trimester, and what's happening with the femur growth, whether if the baby maintains the femur growth on the first percentile, then perhaps it is going to be a constitutional issue when the chromosomes are normal. But if the femur further lags down, then we could be dealing with an evolving non-linear skeletal abnormality.
So in terms of economics, would you like to anyway offer them an FGFR3 at the beginning, or you would just like to wait for everything to come in and then offer it sequentially? And how would your counseling be different?
With FGF, if we have stored the DNA, then in our practice, what we do is we offer it later on if the baby presents with further telling of the growth restriction. And if the baby starts showing some other features of achondroplasia, then we would think about going for FGFR3 mutation.
But from the beginning, if for instance, if we didn't get a trisomy 21 report here, then would you offer it to them anyway to be careful, or would you call them again?
Yes, if it is not trisomy 21, then yes, FGFR would be discussed with the patient and would be offered. Yes.
So back to Dr. Prakash Gambhir, we have this situation where we got this test that came in, but I want you to tell me two aspects of post-test counseling. One is, how do we now tell this patient about this, and what further workup would the parents require, if any? And the second thing is that suppose we did not get a trisomy 21 here, what would you then include in your post-test counseling?
Yeah, so in the first scenario, when we have a FISH result which is positive for Down syndrome, as well as which is confirmed by karyotyping in this case, then it is definitely going to be a Down syndrome baby. And in that particular situation, I will tell the parents, explain them regarding the Down syndrome, what are we expecting from the child if the child is born. So like, for example, the cognitive outcome is not going to be very good. Child is going to be dependent, child is going to live. And after explaining all this, then I will respect their choice. Already this lady has one child, so probably she will like to terminate this child. In case of termination, I will definitely like to work up this child. I think this was showing the trisomy 31 type of Down syndrome, but only FISH was done. Then in that particular case, only 3 signals that can either be a trisomic Down syndrome child, or it can be a translocation Down syndrome child also. So only in case of FISH result, if it is there and the child is terminated, then I will like to confirm whether it's a translocation or a trisomic child, because the risk of recurrence for Down syndrome depends on the type of Down syndrome. So for trisomy Down syndrome, it is not very much increased over and above the age risk, while in case of translocation Down syndrome, it depends on the type of translocation and which parent is carrying it. So according to that, I will advise them regarding the post-termination or post-test counseling in case of it is a Down syndrome FISH result. Now, in case it is not an aneuploidy result, then we got a situation in hand where either it can develop into a skeletal dysplasia, or it can be just a constitutional thing, or it can be associated with a growth retardation. So I will tell them these possibilities. Dr. Aparna has already said that we have to have serial scans to determine whether it is going into skeletal dysplasia or whether it is going to be constitutional. So if it is constitutional, nothing more needs to be done. But in case of skeletal dysplasia, we have to then have a DNA diagnosis as Dr. Kurani was said, on the stored DNA. And I will also ring up my gynecology colleague who has referred this patient to me, saying that this baby may have growth retardation later. So please monitor her hypertension as well as baby's growth. Excellent. Thank you so much for this. And then the final question that we're often faced, and that is that this was a situation where we picked up an abnormality, but we know that the detection rate of screening for trisomy 21 is at best somewhere 80%, somewhere 99%. Even if we use an NIPT, we are sitting at 99.6%. And this is then the most important question. We do have trisomy 21 babies that will either not be screened or be born because the screening failed. And this is for Dr. Archana Kadam. What hope do we have for these individuals after they're born, and how best to guide the parents when screening goes wrong? I am Dr. Archana Kadam. You need to unmute yourself. Yes, thank you. Yes, we're still unable to hear you. You're unmuted, but have we joined with you now? Yes.
All right. Yes. Sorry for that. Now, once a baby is born with Down syndrome, we would keep an eye for ongoing medical or developmental issues. The developmental issues that we anticipate could be in terms of developmental delay. The child could have motor issues as in terms of low tone. So our job as developmental pediatricians is to intervene at the earliest. So if the child has a tone issue, we would start intervention in terms of physiotherapy and keep a track on ongoing developmental needs. Say, for example, the child at 1.5 has expressive language issues, we would start intervention in terms of speech therapy. We have a stimulation program going on for our parents, eventually, as the child grows older, we want to integrate our children into normal setups when they are younger. Though 80% of children with Down syndrome do qualify for mild intellectual disability, with early intervention and doing the right with regular follow-up, we do have a lot of our children, around 10 to 15% of our children, having their cognitive potential in the borderline range. So with better awareness in society and schools, we are able to cater to children with borderline intelligence in mainstream schools with resource room facilities. However, if the cognitive abilities and the situation does demand, the child could need a special school placement. We are also able to deal with behavior issues in our children far better, and we can use medication if there are issues of hyperactivity. Our basic aim of our developmental intervention is to start early and help the child achieve his or her optimal functional outcomes.
Thank you so much, because that really is something that we often realize that we must also share with our patients. We're not all of us aware of all these things, so perhaps a formal referral would make the most sense, which brings us to our final questions of the day and inputs from any of the panelists before we close our panel and move on to our next panel. I must congratulate Varun for that excellent case presentation. Inputs from you and then inputs from anybody else who wishes to make a comment. We do have an audience interaction at the end of the day today at 9:30, and I'd request our panelists to please stay on also for that, so that we can answer some of our audience questions. But we have a minute before we shut, and inputs please. Varun, you first.
Yes, sir. If we have a short femur, we need to cross-check it with the dates. Very often it can be because of wrong dates also. Secondly, we can use the 3D volume probe and use the VCI mode, because even a 1 or 2 mm change in the femur length can change the percentiles or standard deviations very early in the second trimester. And thirdly, if a good first trimester screening is done, and if we find a short femur in the mid-trimester anomaly scan, it is less likely to be an aneuploidy. Rather, it can be a marker for an early onset FGR or preeclampsia or maybe skeletal dysplasia, And if not all, if not anything, then it can very well be constitutional also. So that's it.
Yeah.
Thank you.
So that very, very important point, that first trimester screening will change our complete approach to the observation of a short femur in the mid-trimester scan. Any other inputs from our panelists?
Yeah, just one input. As Varun also said earlier, when we have a short femur on one side, I think we should always measure the other femur, because otherwise we would be missing isolated focal unilateral femoral hypoplasia. So always measure both the femora and make sure that they are similar in length.
Wonderful. Yes, Dr. Gambhir. Yes.
Instead of input, I have one question for both Aparna and Dr. Aparna and to you.
Yeah.
Is that I have encountered quite a lot of fetuses with femoral facial abnormality. So what is your experience regarding this particular condition? It is said that it is more common with gestational diabetes. What are your opinion? What is your opinion regarding this?
So you're saying, and what was the face abnormality?
Face abnormality is a very typical face with broad philtrum, antivertedness, thin vermilion border of upper lip, and short femurs.
Right.
Sometimes it is said to be overlap between kyphomelic dysplasia and femoral facial abnormality.
Yeah, so it's a very well-defined syndrome, of course.
Yeah.
And it's just so important to realize that protocol is really extremely important. We find very often, even in the images that come to us, a femur which has been measured in a vertical direction instead of a horizontal direction. So that is something that the practicing obstetrician should be aware of. And then the fact that the actual list of what we look at in ultrasound is constantly expanding. We do understand that some of the facial dysmorphism may not show up much later. So it would be relevant to, of course, discuss this in the next two panels. But it's wise also to realize that the face forms such an important part of our evaluation in the second trimester anomaly scan. My thanks to the panelists, and we come an end to this panel and we hand over to the next panelist. Thank you indeed for your inputs. It's been a very stimulating panel, and thank you very much indeed.
Thank you.
Yeah. Sure.
Next panel now. Yes.
Yep. Good evening and wonderful, Ashok. It was a great panel and you took us through various aspects of it. And one of the most important thing which you made us all realize is that first trimester screening is an extremely important parameter in evaluating a short femur. Now, you have shown us a lot of data, and now I thought I'll show more of cases so that when SFM members who are more keen on seeing images can also get the visual pleasure. Okay, so shall I share my screen? I'll share my screen. Yeah.
Yes.
Yeah. Okay. Coming to short femur, actually, I would like to, I think I would like to have our Chaudhary to give us the presentation. Before I share the screen, I think I would like to ask Dr. Chaudhary to come up with his case presentation. He has done a wonderful job. He has prepared a wonderful case, and which is one of the most important presentations that I thought it will be very worthwhile. Yogesh, can you share your screen? Sorry for that.
Is it fine, sir, from my side?
Yes. Your marker is also seen. Go ahead.
Yes, sir.
Yogesh?
Yes, sir.
Please start.
Thank you, sir. First of all, I would like to thank SFM and all respected teachers to give me this precious opportunity. And thank you, TL and Praveen, sir, for sharing a few images for the case presentation. Yeah. So I will be presenting couple of cases. The first case is a 26 years old primary, no significant past history, and gestational age was assigned as per LMP. Her NT scan and anomaly scan was done, which showed normal parameters, and her biochemical screening was low risk. There was no significant family history, and the present pregnancy was uneventful. She came for the growth scan. So the striking features were the large head with frontal bossing. There was a macrocephaly and there was a depressed nasal bridge. The fingers were short and stubby, and liquor was slightly on higher side. In addition to that, all the long bones were short, like here you can see radius and ulna were less than 5th percentile. Then the femur length was again less than 1 percentile. One important sign that we would like to share for this case is a Caller-Hoof sign, where the epiphyseal metaphyseal interface is slightly rounded and it makes the large angle with the shaft of femur. So it is a diagnostic of this condition. And the 3D image showed the similar findings like short limbs, especially rhizomelic shortening of all the limbs, narrow chest, protuberant abdomen, and the macrocephaly. And the 3D spine showed slight lordosis of the lumbar spine with the narrowing of the interlaminar distance. So this was the biometry chart of this fetus. The gestational age was 23 weeks 5 days and the average growth was 20 weeks, and if you see, all the long bones were less than 1 percentile. So to summarize with the findings, there was a relative macrocephaly, frontal bossing, rhizomelic shortening of limbs, short fingers, small chest, and polyhydramnios. So considering these findings, we made the diagnosis of achondroplasia in this case. Over to you, sir.
Thank you. Thank you, Yogesh. It was a wonderful presentation. And most important thing that he has put forward one of the most important signs, that is what's called as the Caller-Hoof sign, and which is very, very pertinent as far as the achondroplasia is concerned. Normally, the angle between the epiphysis and the metaphysis are usually acute. Whereas whenever we, can you unshare your screen?
Yes, sir.
Whenever we have this sort of a problem where there is an achondroplasia, this angle becomes more. Normally is about 110 degrees angle. Whereas when it becomes more than 140, you consider it to be a Caller-Hoof sign being positive. Once you see this Caller-Hoof sign with all other features which has been described in the case presentation, it obviously indicates that it's an achondroplasia. Now, with this, I think we will start off with the present panel. I have a wonderful panel with me who have been, who actually they don't need any introduction. Today's topic being short femur. And first and foremost thing, you have seen Yogesh presenting his case, which is wonderful achondroplasia, which has described all the features. At the same time, he has also given us one of the most important signs which are really diagnostic about achondroplasia. Then we have Santosh Shabnis. Santosh Shabnis is a very dynamic person. He has been a consultant radiologist practicing ultrasound for the past 18 years, and he is now the president of SFM Pune. And we wish him all the best, and I'm sure he's going to take Pune SFM to a very great height as far as the academics are concerned. Then we have Meena Nagarwa. She is a consultant medical geneticist, and she has been, she's basically a gynecologist, did her DM genetics from Sanjay Gandhi, Lucknow, PGI. And then she has almost 32 publications to her credit, and she has been contributed 2 book chapters. And she's also the founder of Geni Clinics in Pune. Now we have Neha Agrawal, a young fetal medicine specialist who has been with Dr. Arun Kinnare, and she has specialized in fetal medicine. And now she is the HOD of fetal medicine in Cloud9 Hospital, Pune. She was trained in King's College for fetal echocardiography, as well as in fetal therapy. She was trained at Neckars, Paris. So these are the illustrious panel which I have with me, who is going to talk to us about various aspects. Before they start off doing, I'll just give you a brief introduction of what to look for and how to look for as far as the short femur is concerned. Now, we all know that whenever we try to evaluate a fetus, the first and foremost thing is the biometry. And in the biometry, one of the long bones are the ones which we measure. And the femur is the common factor which we try to measure in the mid-trimester in order to assess the biochemistry. Whenever we find this sort of a short femur, we need to think of various possibilities, which actually the previous presenter has already told us that it could be a chance finding. Quite often it's a chance finding, and it may be because of inaccurate measuring or inaccurate dating. Also, it can be a normal variation or a constitutionally small fetus, or it could be because of fetal growth restrictions, skeletal dysplasias, chromosomal abnormalities, or a syndromic anomaly. So these are all the things that will come across to you as whenever you see this sort of a short femur. Now, when we see a short femur, we basically classify the short femur into two components. That as one, it could be an isolated one. That is, you do a thorough fetal survey, and then you find that there is no other finding, then you label it as a isolated fetal short femur. It accounts to almost 2/3 of the cases. That is what is very, very important. Whenever you find this sort of an isolated short femur, the possibilities are it could be a false positive, that is improperly measured femur length, or it could be because of severe preterm IUGR, or it could be unexplained. In this situation, the first and foremost thing we do is to do an umbilical artery and the uterine artery Doppler in order to rule out the possibility of a fetal growth restriction. Now, the other clinical scenario which we come across is non-isolated. That is, it is associated with some other abnormality. In that situation, we need to think in terms of a skeletal dysplasia or multiple abnormalities or an abnormal karyotype or a genetic syndrome. So this is the approach which we are going to take as far as the short femur is concerned. So basically, when you have identified it as an isolated short femur, it could be a false positive diagnosis. And then the most important thing that we have to do is the uterine artery and umbilical artery Doppler to rule out the possibility of early onset FGR. Remember that you can almost rule out the possibility of aneuploidy if the lady has got a proper first trimester screening with NT as well as the combined screening. The possibility of aneuploidy is not considered. Now, whereas it is a non-isolated femur, short femur, in that situation, 1/3 of the cases are skeletal dysplasias, and the femur length corresponds to less than -2 standard deviations, which is considered to have a skeletal dysplasia. But then, unfortunately, some of these FGRs also fall into the group between -2 to -4 standard deviations. That is the reason why we need to be much more sure. In that situation, we definitely need to do a uterine artery Doppler to rule out the possibility of GR. So basically, we need to first and foremost think in terms of a possible growth restricted fetus, which is contributing to a smallness of the fetal femur, or it could be because of the constitutional. Then we need to think in terms of possible skeletal dysplasia. So this is the approach which we have to follow whenever we have a short femur. Now, how short is short is what is the question that it has to be answered. Now we have this bell chart which explains us regarding the standard deviations. If once we have a 2 standard deviations, it accounts to almost 95% of the distribution. And if you have a femur length which is less than 1 to 4 millimeters when compared to the standard deviation of that gestational age femoral length, then you definitely need to be more cautious and to need to follow them up very thoroughly in order to rule out the possibility of skeletal dysplasia. If it is more than 5 millimeters, then positively we know that it is a greater likelihood of a skeletal dysplasia. But whenever we have a -2 standard deviation in the second trimester, they should be evaluated further. So the most important message which I wanted to convey as far as the short femur is concerned, quite often, most of our nomogram charts are available between 5th and 95th centile. But then if we take this nomogram charts and plot our femoral lengths, almost about 2.5% of all feti will have short limbs. That means it is a gross overestimation. That is the reason why whenever we are dealing with a skeletal abnormality, it is always essential to plot your measurements on a growth charts which are available between 1 and 99th centile. In that situation, we may have only 0.5% to be considered as short limbs. So that is extremely important, because or else we will be unnecessarily creating unwanted anxiety in the parents. So this is one important message that we have to take home. Now, basically, broadly, when you take the short limb or a short long bone, the first and foremost thing is if it is diagnosed in the 11 to 14 week scan, it is usually lethal. If it is diagnosed in 20-week scan, it is non-lethal. Whereas if it is diagnosed in third trimester, we need to work out for placental insufficiency and fetal growth restriction, which Vimal is going to take us through. Now, coming to the ultrasound, the most important message is that on ultrasound is not diagnostic of a skeletal dysplasia. It is basically intended to differentiate between a lethal and a non-lethal dysplasia. That is what is the most important goal that we need to achieve. In order to do that, we need to measure all the long bones, at the same time assess the morphology, which, as Dr. Ashok has already told us, that the importance of evaluating the morphology, and which will definitely help us in identifying the lethality of the condition. Now, confirmation is basically by molecular testing, and as well as the prenatal and postnatal X-rays, autopsies, histomorphic analysis of bone and cartilage. So these are the things that we need to follow in order to confirm a diagnosis. Now, skeletal dysplasias, basically we need to understand that there are almost more than 460 types, variety of heterogeneous group, and of which about more than 80% are known to us. Quite often they present as autosomal dominant or recessive or X-linked, and rarely as a chromosomal abnormality. So these are the things that we have to have a broader concept about the short limbs. Now, whenever we have a short limb, as it has been stated by Ashok also, that we need to look for certain parameters, like this, the presence of the bone or absence of the bone. As you can see here, you can see that the radius is absent, and this is classical radius reaplasia. Then we need to think in terms of measure the growth and assess the opposite femur, as Dr. Aparna and Dr. They have suggested that we need to measure both the femuri or the humerus in order to assess the growth pattern. Then we need to identify the pattern of the bone, that is the type of presentation, whether it is a telephone receiver deformity, and at the same time, we need to understand the structure or the morphology of the bone, that is the presence of multiple fractures and abundant callus formation. So these are the things that we need to consider whenever we have a short bone. And keeping this in mind, the ultrasound features which enable us to label a skeletal dysplasia as a lethal dysplasia are that: one, if we have a long bone which is less than 4th standard deviation, or a head circumference which is more than 75th centile, because as you have seen, even in achondroplasia, which Dr. Yogesh has shown us, that there was macrocephaly. Most of the skeletal dysplasias do have macrocephaly, and this disparity between the head and the long bone is one important factor. Then we need to get the fetal length, the femoral length, as well as the abdominal circumference, which is usually less than 1.16. And then the femur to foot ratio is extremely important, particularly when we are labeling the fetus as a rhizomelic fetus, where we have normally it should be 1 throughout the pregnancy, but whenever it is altered and whenever it becomes less, then we know that the femur is definitely short. So instead of having a visual impression or a subjective method, you can have an objective parameter by taking what is called as the femur to foot ratio. Then we have the thorax to be evaluated. Quite often they are associated with hypoplastic thorax. And whenever we have a thoracic circumference which is less than 5th centile, and cardiac chest circumference more than 60%, that is the heart is bigger and the chest is smaller, TCAC ratio were less than 0.79, and bell-shaped thorax. These are the things that we have to have. And most of the lethality is basically because of hypoplastic thorax, because of pulmonary hypoplasia, resulting in neonatal or perinatal morbidity and mortality. Now, the specific features are the cloverleaf skull, which is quite often seen in thanatophoric dysplasias type 2, and extensive multiple fractures. Now, they are usually associated with hydramnios and hydrops. So these are the features that we have to keep in mind whenever we try to label a skeletal dysplasia as a lethal dysplasia. The reason why I'm stressing this is that the most important thing as a sonologist or a radiologist is to differentiate a skeletal dysplasia as a non-lethal skeletal dysplasia or a lethal skeletal dysplasia. That is the first and foremost goal of all of us. Now, keeping this in mind, this is the way you take the femur foot length ratio. And then the other things are the thorax, which is definitely smaller when compared to the abdominal circumference, which is 0.77. And then we have the transverse thoracic circumference being 5th centile. And you have this bell-shaped thorax and a narrow thorax with a protuberant abdomen are very, very classical of hypoplasia of the thorax. And the rib abnormalities like this, you can see flattened, fractured, dysmorphic ribs with the presence of thickening of the abdomen, chest wall. And also we have skull abnormalities, as you can see here, frontal bossing, deep nose, deep nasal bridge, as well as the clover leaf appearance. So these are all the various abnormal shapes. Not only that, you can even assess the morphology or the mineralization of the bone, particularly the cranial bones is extremely important for us, so that you can see whenever you take the axial section of for the transthalamic measurement, that is the biparietal diameter, if you see the anterior cerebral hemisphere much as clear as the posterior cerebral hemisphere, or the cerebral hemisphere away from the transducer, you are obviously thinking that there is a possibility of a bone, poorly mineralized bone, because it is allowing the sound. Not only that, normal skull can never be compressed, whereas if you can compress the skull, as you can see here, obviously you are dealing with a poorly mineralized skull vault. So these are all the various features that we have to keep in mind. Now, whenever we find a case, basically now, the index feature is that you have either a severe micromelia or a rhizomelia. If it is a severe micromelia, you need to look for the additional signs. This is basically, I am talking about non-isolated short, long bones. In this, when you take the additional signs, if you take the thoracic hypoplasia as the additional sign along with micromelia, you need to think in terms of a thanatophoric dysplasia type 1. If there are multiple fractures and hypomineralization, possibility of a osteogenesis imperfecta with type 2, and then thoracic hypoplasia with hypomineralization, then you need to think of chondrogenesis, severe hypomineralization, hypophosphatasia, and thoracic hypoplasia, polydactyly, hypomineralization, short limb polydactyly syndrome, SRPCPS. So these are the possibilities that you have to entertain. Similarly, when you have a rhizomelia, taking the additional features, you can come to a conclusive diagnosis based on the index sign as well as the additional signs. Now, this is one reporting format which I would advise, or which I would suggest that all of you should follow whenever we are dealing with the skeletal dysplasia. This is available from University of Washington, which they have prepared a wonderful reporting format wherein you can download this very freely. And once you have all the parameters which I have described are available here, and if you start entering all those things, you will reasonably come to a very positive differential diagnosis and a possible diagnosis. Now, let us start off with the first case. Dr. Santosh, are you there? Hello? Hello?
Yes, sir.
Yeah. So can you go ahead? This is one of the ladies who have presented to us at about 20 weeks of gestation. And these are the images. I would like you to describe the images and then give us the findings. So these are you can please go ahead.
Yeah. So the striking feature, as Praveen sir has shown before, is the shortening of all the long bones, which is seen very nicely here. The head is obviously very large, so there is microsomia. And okay. The characteristic feature is the femur, which is short in size, and the classical telephone receiver deformity, a bowing of the femur, is a classical hallmark of this case. And the trunk is small and narrow, and the thoracic hypoplasia is present. On the spine image, you can see there is platyspondyly, which is flattening of the vertebral bodies with increase in the intervertebral distance. The vertebrae are obviously small in size and flattened as well. Yeah. The head size is large, and there is deep nasal bridge depression of the nasal bridge, and there is associated frontal bossing as well. There is upturning of the nasal tip. The thorax is hypoplastic and the protuberant abdomen is seen. So obviously the thoraco-abdominal ratio is also deranged. The classic telephone receiver deformity of the femur, which is very small and bowed, and the classic appearance is seen. And according to visual impression itself, it shows that the large long bones are extremely small, maybe less than 1 or 2 standard deviations. So to summarize the UAG features of this case, there are very short, long bones. There is classical telephone receiver deformity of the femora. The ribs are short and horizontal, and there is a narrow, small thorax. And because of that, the cardiac size is normal and the thorax is small. So you do tend to get an abnormal cardiothoracic ratio as well. Because the thorax is small, the abdominal thoracic circumference ratio is also deranged. There is platyspondyly that has been shown very nicely. There is frontal bossing and depression of the nasal bridge, and there is associated polyhydramnias. All of these are classic of thanatophoric dysplasia type 1, in which all these classical features are seen. There are two types of thanatophoric dysplasias, all of us know. Type 2 is when you have a clover leaf skull, what is known as Kleibert-Stachel, in which there is the shape of the skull is absolutely classic, and this is a diagnostic hallmark for type 2 skeletal thanatophoric dysplasia. It is not very common. Type 1 is the commoner finding. And again, there is the long bones are short, but they are less severe as compared with type 1. Thanatophoric is a very common lethal skeletal dysplasia, and the prevalence is in 1 in 10,000 births. As I discussed, there are two types, type 1 and type 2. Type 1 is hallmarked with telephone receiver femur, while type 2 is rare and it has this clover leaf skull sign. And the condition is lethal because of the presence of pulmonary hypoplasia. Because the thorax is small, the lungs are not able to grow. And because of the pulmonary hypoplasia, this is a very lethal thing. And there is no recurrence, no increased risk in the future pregnancies.
Now, can I ask Meena to pitch in and tell us about the genetics involved in thanatophoric dysplasia? Dr. Meena?
Yeah, thank you, Dr. Praveen and Dr. Chaudhary for excellent slides. So as already described by Dr. Yogesh, that thanatophoric dysplasia is one of the most common lethal skeletal dysplasia. And I agree with Dr. Praveen that as an ultrasonologist or fetal medicine expert, the first and foremost is to differentiate between lethal and non-lethal. But when we talk about genetics, because as most of the times it becomes important to make a molecular diagnosis, which makes our genetic counseling, prediction of risk of recurrence, and prenatal diagnosis easier. So as you can see on the screen, this is caused by a mutation or a harmful genetic variation in FGFR3 gene. And if you can remember the discussion by Dr. Khurana, that FGFR3 is the gene which is causing the most common non-lethal skeletal dysplasia as well, which is achondroplasia. So this case is the classical example of one gene and multiple phenotypes, and that skeletal dysplasia is notorious. So for all the clinicians here, for all the sonologist experts here, the one thing which genetic laboratory needs is the clinical interpretation and document all the clinical findings, what you have found in any fetus. The best would be the postnatal radiographs, as Dr. Praveen already described. But if you can preserve the ultrasound images and document each of these findings, it will help geneticists to make a genetic diagnosis and genetic laboratories to provide a relevant diagnosis. And also, as I will go with Dr. Praveen and Dr. Kinnare initially, that we should not be ordering unnecessary genetic tests. So once we have figured out this is a lethal skeletal dysplasia, we have to talk to the family actually what we are going to achieve with the genetic diagnosis, because in next pregnancy, even if the risk of recurrence is higher, the diagnosis will be made not before 12 to 13 weeks by CVS and targeted mutation testing. So if anyways this is lethal, the diagnosis would be made at 12 to 13 weeks. So it's good to know about genetics, but we need to see the cost-effective diagnostic yield in every family.
Thank you. Thank you, Dr. Meena. With this, shall we move to the next case for Neha Agarwal? Dr. Neha, can you?
Good evening,
yeah,
sir.
please go ahead.
Yes, so in this image, we see the most striking feature here is that the vertebral bodies are very poorly ossified. Yes, from top to bottom. So can we go back?
Yeah.
It also shows a presence of a very short neck and short trunk. The thorax is also smaller in comparison to the abdomen. So the tummy is protruding out, which means the thorax is slightly smaller than the abdomen. And the short neck and poor mineralized vertebral column is very prominent.
Yeah, very nice.
Okay. Here we see a very poorly mineralized cranium. Sir told us that we shouldn't be able to compress the cranium, which we can see in the right image. And in the left image, the whole cranium is, especially the distal margin is very clearly seen, which means that the mineralization is poor. So the sound waves are able to pass through the posterior margin. So the mineralization is defective. Okay. The most striking feature here is that the limbs are very short. If you see the ulna and the humerus, which are measured and written in yellow, they are way below the 5th centile. So the limb is extremely short and the bones are hypoplastic. So it's a micromelia.
Sorry.
Okay. Yes. So if we club all these features, which is marked shortening of the limbs, hypoplasia of the bone, short trunk, thorax, neck, poor vertebral ossification, and poor mineralization of the cranium, it all can be clubbed into, yes, achondrogenesis, which is also known as osteochondral dysplasia. Right, sir.
So, Meena, can you please tell us about the pathogenesis of achondrogenesis?
Yeah, as Dr. Neha described wonderfully, this diagnosis is almost clear to every experienced eye. And as the achondrogenesis name say, achondrogenesis, that is a defective cartilage formation. And this is one of the rare, not so common skeletal dysplasia with a prevalence of 1 in 40,000 to 60,000. But looking at the group of lethal dysplasia, skeletal dysplasia, the prevalence is 1 in 20,000. And looking at the India's population and birth rate, nothing is rare in India. So we see these cases often. And as you can see on the screen, there are multiple types of achondrogenesis, but each type is caused by a different gene. So unlike the previous example, I would say this is a classical example of one phenotype caused by multiple genes. And not only the multiple genes, you can see that mode of inheritance is also different. Like 2 of genes are autosomal recessive with risk of recurrence is as high as 25%. And the mutation in COL2A1 is the autosomal dominant. I would just like to highlight for this audience that when the laboratory or geneticists say this is an autosomal dominant, it doesn't mean that it is inherited from either of the parent. It just means that out of 2 copies of the gene, mutation in 1 copy of the gene is sufficient to produce a disease. Because achondrogenesis is a lethal disorder, the reproductive potential is 0. But if we know that, okay, this is a disease or a condition called by COL2A1, which is autosomal dominant and caused by a de novo mutation and not by the inheritance, the risk of recurrence is next pregnancy is negligible. While in other 2 cases, the risk of recurrence is 25%. And that becomes important if family opts for genetic diagnosis and helps us in prenatal diagnosis and genetic counseling.
Thank you. Thank you. Thank you very much, Meena. Neha, what about the prevalence and prognosis and recurrence? Part of it has been answered by Meena, but then I would like you to go through it and let us know about it.
Yes, sir. Achondrogenesis is the second most lethal common skeletal dysplasia, only after thanatophoric and achondroplasia. The prevalence is known to be very less, 0.09 to 0.23 per 10,000 live births. And the prognosis is extremely guarded. These fetuses usually are stillborn, or if they are born, they usually die due to respiratory disorders very soon on at birth. And as we know that the type 1A as well as the B are autosomal recessive, so the recurrence risk is 25%. Kids will be affected, 50% will be just carriers, and just 25% will be completely normal. However, type 2 is sporadic and it is caused by those specific genes.
Yeah. Thank you. Thank you very much. Now, Yogesh, can you just take over this case? This lady is again come to us at about 20 weeks of gestation, and these are the images which you have.
Yes, sir. So she came for anomaly scan, and the most striking feature was that all the long bones were very short. Like here we can see this femur, which has also got a bending, and the mineralization is less. They are looking relatively less ecogenic than the routine femur ecogenicity. In these images, we can see the ribs are parallel and they are showing a bending, and the mineralization is also low. So this is because of the bone fractures, multiple rib fractures. In here, this is the coronal section. What we can see is the extremely small diameter of the chest. So it is a bell-shaped chest with protuberant abdomen. And here again, you can see the hypomineralization of the long bones there. And there are fractures. Here in this video, we can confirm all those findings. The extremely short curved bones. There is a polyhydramnios. In addition to that, there is a narrow thorax and poorly mineralized cranium. So all the findings, considering all these findings like markedly short femur, marked hypomineralization of bones, multiple fracture and small thorax, we made the diagnosis of osteogenesis imperfecta in this case. Yes, sir.
What is the prevalence and the types of osteogenesis imperfecta we would like to know?
There are almost 8 types described in the literature of osteogenesis imperfecta. The prevalence is 1 in 15,000 live births. Out of 8 types, the common are type 1 and type 4. The spectrum of defects are characterized by fragile bones that we have already seen. Type 2 and type 3 are which we can prenatally diagnose which can be easily diagnosed. Type 1 presents with fractured long bones in second and third trimester. Type 2, it presents with the short limbs and ribs with multiple fractures and poorly mineralized skull. And type 3 presents with multiple fractures and very short stature.
Thank you. Thank you. Meena, can take us through the genetic predisposition of this osteogenesis imperfecta, please?
Yeah, so just to add on what Dr. Chaudhary said, that yes, there are multiple types of osteogenesis imperfecta, and I will combine previous two phenomena. This is one gene, multiple phenotype, and one phenotype and multiple genes, because the most common genes like COL1A1 and COL1A2, which is responsible for 85 to 90% of the cases, they can cause very severe type 2, type 3, lethal and very severe disorder, to type 1 and type 4, which is kind of mildly symptomatic and highly variable. Apart from these two genes, the literature has 19 more genes for causing the similar phenotype. Some of them actually may be that severe. And while on the one hand, COL1A1 and COL1A2 is autosomal dominant disorders where only heterozygous mutation is required, these other genes are mostly autosomal recessive, where the risk of recurrence can be as high as 25%. And here is the scenario where I would really suggest to, if you have a suspicion of this diagnosis, DNA storage and ask for a genetic diagnosis, because here there can be a variability in presentation, and prenatal diagnosis in next pregnancy would be certainly helpful to the families. Yeah.
I think probably I think we lost connection there.
Hello. Hi, Dr. Praveen. Can you hear me?
Yeah. Now we can hear you. Please.
Was my connection lost?
Yes.
So I was just saying,
please go ahead.
Out of these three scenarios what we presented, this is the one where I would really recommend to store the DNA and look for a molecular diagnosis because of the variability of presentation. And actually here we can help the families in finding out the targeted mutation in next pregnancy by chorionic filler sampling. One word about non-invasive prenatal testing. Laboratories in India claim about non-invasive prenatal testing for single gene disorders, but clinical validity still has to be proven. So just be cautious when the laboratory talk about non-invasive prenatal testing for single gene disorders.
Right. Thank you very much. And I think our panel has done a great job in presenting three lethal abnormalities, lethal skeletal abnormalities, and Yogesh has presented to us a non-lethal achondroplasia. And in total, we have given you some of the commonest occurring skeletal dysplasias, which we have to remember and which we are going to come across in our day-to-day practice. Now, the key messages as far as this panel is concerned is that don't use terms like bronchitis, seeing a chest X-ray or and use first centile whenever you are trying to evaluate the length of the bone. And in the second trimester, keep worrying about the possibility of a genetic problem. In the third trimester, particularly, you definitely need to think in terms of a possible statistical variation or a growth-restricted fetuses. And always follow the algorithm, that is, take the index sign and then add the additional features, and then you can easily come to a diagnosis. Please follow this report format, which is published by the University of Washington, which will definitely help us to methodically and meticulously evaluate the skeletal abnormalities. Counseling of these families and their physicians. This word I'm specifically insisting that their physicians to consider obtaining and storing tissues and or DNA, especially because many skeletal dysplasias are associated with significant recurrent risk. So this is an extremely important message that it has to be carried on to the physician who is referring us the cases. And remember, particularly the skeletal dysplasias, we definitely need to have a multidisciplinary approach. We need to involve the sonologists, perinatologists, all these people are essential in coming to a reasonable diagnosis. But in spite of all these things, we need to understand the correct diagnosis can be achieved by ultrasound in about 30 to 40% of the cases. In about 40 to 50% of the cases, the specific diagnosis is not possible. And quite often we will be incorrect in almost about 18 to 20% of the cases. Now, there are certain resources that are available, such as the International Skeletal Dysplasia Registry, as well as the European Skeletal Dysplasia Network, which will definitely help us in the sense, if you can put forward your data, they will definitely help us in arriving at a reasonable conclusion. With this, I thank all my panelists. I thank the audience, as well as my friend Ashok for giving me this opportunity to do this one. Thank you very much.
Thank you, sir.
I think, can we ask Bimal to take over?
Yes, and we also need a little slot for our trade presentations once. If we can do those and then move on to our final one. Bimal, a short slot for our trade presentations.
Yes, sir. Yes, sir.
Yeah.
Thank you and good evening, everyone. At the very onset, would like to congratulate the complete team of the Greater Pune chapter of SFM for eventually having their chapter. In fact, two very passionate people, Dr. Santosh Sabnis and Dr. Chinmay, they have been in conversation with me since last 1.5 years. And every time I think we met or we talked, sir, we'll start our own chapter, sir. We'll have the Pune chapter. And I said, okay, you'll decide, we are always there with you. The moment but the thing should come from you all. And then unfortunately the lockdown came and eventually it has happened. And I'm very happy that both these passionate people are at the helm of affairs, and I'm very, very confident that they will take this chapter to very, very great heights. And I would also like to tell you that, yes, I am, I like all the chapters, but definitely this chapter will be very close to my heart. And, I'm the closest person to Pune, so I'll be keeping a lot of watch and giving you a lot of trouble in the next few years to come. With this, we move to our third panel, and we've already had a panel on the Down syndrome and skeletal dysplasias, and actually right from the beginning, the reasons for a short femur, which were talked about, and all those who have talked about skeletal dysplasia have already covered constitution. So since everything else is ruled out, I think we are very fortunate. Everything has already been done for us. So the last thing that remains is FGR. So for us, the diagnosis is becoming easier and easier. And with this, I would like Dr. Manali Rahalkar to present her case. And she's a consultant radiologist at Gupte Hospital, Pune. And she's an ex-associate professor in radiology from BJ Medical College. And Manali, can you share your screen and show us your case?
Okay. Am I audible, sir?
Yes, sir. Yes, Manali. Absolutely.
Good evening, everyone. At the outset, I would like to thank Society of Fetal Medicine for giving me an opportunity to present a case in today's inaugural meet. And also I would like to thank Dr. Bimal Sahani sir for guiding me for preparing this presentation. So with today's theme being short femur, I will be presenting a case on fetal growth restriction. So this was a 27-year-old primary gravida from natural conception from a non-consanguineous marriage who came for a follow-up on routine at 33 weeks of gestation. Her history was that she was a case of gestational diabetes on insulin since 12 weeks of gestational age. She was also a known case of hypothyroidism on treatment. There was no other significant history, no hypertension or PIH. An early dating scan was done at 6 weeks, 1 day, which was corresponding to her LMP. The NT scan, along with the aneuploidy screening at 12 weeks, 4 days was normal. And the anomaly scan, growth scans, Dopplers, and all scans done up to 28 weeks were normal. So to summarize, this was a singleton pregnancy without any fetal pathologies like aneuploidies or skeletal dysplasias or any genetic syndromes. So this was how the growth parameters looked at 33 weeks. We can see that the AC and the FL are smaller, and also that the FL is at a lower percentile as compared to the AC. So at this point, at this time, I would like to point out that sometimes short AC is not the first parameter to lag behind in cases of FGA or SGA. Sometimes you can have an isolated FL also, which can be a marker for FGA and SGA and FGR. So coming back to this case, the expected birth weight was 1712 grams, which was at 16th percentile. The patient had a good AFI and a biophysical profile was also good. Then this was the Doppler done. And the Doppler showed that the mean uterine artery PI was at the 92nd percentile. It was slightly on the higher side, but since we consider 95th percentile as a cutoff, we considered it at normal at this time. The umbilical artery PI and the MCA PIs were normal. So the Doppler was normal in this case. This is how the growth charts looked at 33 weeks. And since this was a small fetus with normal Dopplers, we classified it as a SGA fetus. And we kept it under surveillance and called the patient for a follow-up after 2 weeks. So after 2 weeks, when the patient came for a follow-up scan, she was 35 weeks, 4 days by LMP at that time. And she was also complaining of decreased fetal movements. So when we did a biometry, we found out that now all the parameters have fallen below the 3rd percentile. And the weight at that time was 1904 grams. This is how the growth chart looked at 35 weeks. And we can see that there is a classical flattening of the growth curve that we see over here. We also looked at the Doppler. On this side, I have Dopplers. On the right-hand side, the Dopplers at 35 weeks. And for comparison, the Dopplers done at 33 weeks. Now we can see that the mean uterine artery PI was 1.1, which was at the 99th percentile, which is abnormal for this gestational age. We also did the umbilical and MCAs. The umbilical artery was normal, but the MCA showed a lower PI, which was at 4th percentile for this stage. Then we calculated the cerebroplacental ratio, which is a marker for fetal hypoxia. And we found out the cerebroplacental ratio was below the 5th percentile, and it was normal at the previous 33-week scan. The AFI of the fetus was also less. It was 7.2, and it had dropped down to 7.2 from 11.8 at 33 weeks. When we examined the biophysical profile, we found that was also unsatisfactory, and the score was 4 out of 8. The patient also underwent a NST, but however, that was not conclusive. So the diagnosis in this case was a late onset FGR because she had presented after 32 weeks and she had abnormal Dopplers. The factors in this case was that she had a falling, the NST was unequivocal. The patient also had oligohydramnios. And all this was in the background that the patient was persistently complaining of decreased fetal movements. So after consultation with the treating obstetrician as well as the patient, it was decided to deliver the patient by LSCS at 35 weeks, 5 days after administering steroids. And a female baby was born of weight 1990 grams. The baby cried immediately after birth. The oxygen saturation was 99 percentile. The BSL was 86. The baby was shifted to the NICU, had a short stay of 6 days and was discharged after that and is doing well now. Thank you for your kind attention.
Thank you, Manali. And now I'll share my screen. Okay, we move to this panel discussion, and I have a very light panel. We have Dr. Girija Wagh. Yeah, she's joined, and she was busy with an emergency, but yes, she's made it at the right time. And we have Dr. Sandeep Kadam, Dr. Chinmay Umarji, and Dr. Manali Rahalkar. Dr. Girija Wagh is an obstetrician she's a professor of OBGY at Bharati Vidyapit Medical College and Hospital, and she's a consultant at Cloud9 and Apollo Spectra, Pune, and also at the Girija Hospital and Fertility Center, Kothur, Pune. She's got a lot of awards, and you can see from this list that yes, she is very much for academics, and she is a great teacher. This is the feedback that I've got from some of her students. Then Dr. Sandeep Kadam is an MD Pediatrics with DM Neonatology. He's a consultant neonatologist at KM Hospital, Pune. It's nice to have a neonatologist in this panel, which is concerning FGR. Dr. Chinmay Umarji, the latest addition is that he's the secretary of the Pune chapter, the Greater Pune chapter of SFM. And then he is, he's again an obstetrician, but with a research fellowship in fetal medicine. So I think, he's a combination of both clinical obstetrics plus fetal medicine, and does both with a lot of passion. And he's a visiting expert in fetal maternal medicine at Sassoon General Hospital. He's a consultant at the Sayadri Hospital, Deccan Umarji Hospitals, Pune. And again, he's a member of the Antenatal Screening Committee, Government of Maharashtra. There's so much I can talk about him, but okay, due to time restraint, we restrict to that. And Dr. Manali Rahalkar, I have already said, is a consultant radiologist at the ultrasound clinic, Gupta Hospital, Pune. Okay. Now, a short femur is not a very atypical finding. Femur length less than 10 centile. You can say, that is the one thing which actually catches you. The definitions is that we need to use a less than 5th centile. As a part of a skeletal dysplasia, we need to go down to less than 2 centiles or 1 centile. Dr. Praveen has talked about. So yes, it can be a normal variant. Inaccurate dating, one of the most common times you see is that the dating has not been done well. It's a marker for aneuploidy, skeletal dysplasia, and FGR. Now, this is when we talk about FGR, this is very common, where you see a short femur with AC and estimated fetal weight less than 10 centile. But at times you may find a short femur, but the AC and estimated fetal weight greater than 10 centile. So this can happen even in the 3rd trimester, but this is something what starts worrying you right in the 2nd trimester itself. So Dr. Manali, can you get a femur length which is less than 10 centile, but an estimated fetal weight which is greater than 10 centile, and even an AC which is greater than 10 centile?
Yes, sir. We can have a FL less than 10 percentile with an EFW or AC which is more than 10 percentile. And in such cases, we will call it as an isolated short femur, only after we've ruled out aneuploidies, genetic syndromes, and skeletal dysplasias. And the important thing about this isolated short femur is that it is associated with FGR or SGA. And we should follow up such fetuses with a growth scan and a Doppler, so that we can diagnose FGR at the earliest.
Okay, thank you. Now, right in 2008, there is this wonderful study by Papargio, where you need to call the cases of short femur less than the 5th centile and divided them into isolated and non-isolated. Non-isolated were the ones which had the skeletal dysplasia and multiple abnormalities, abnormal karyotype, and genetic syndrome. Amongst the isolated, he found that, of course, 13% were false positive, but 40% of them eventually were associated with severe preterm IUGR, and 47% were unexplained, constitutionally small, and others. And in fact, in his study itself, 50% of the ones which were eventually associated with FGR had an abnormal uterine artery in the 2nd trimester. Then this wonderful study from 2012, where they found, of course, they took the 10 centile as a cutoff, and isolated short femur less than 10 centile was associated with FGR 3 times more than the ones with a normal bone length. And then it was also associated with preterm birth before 37 and 34 weeks, and also associated with an increased incidence of intrauterine fetal demise as compared to fetuses with normal bone length. And hence they concluded that a short femur length may be an early sign of placentation and placental insufficiency, thereby providing biological plausibility to the association observed between short femur length and FGR. And then in 2018, this meta-analysis came, the meta-analysis on the mid-trimester isolated short femur. And if you look at this comparison between the study group, which was the ones with a short femur, and the ones which had a normal femur, and you can see that IUGR and SGA was 14.2 versus 5.2, low birth weight 22.1% versus 8.67%, Apgar score less than 7 at 5 minutes, again higher, preterm birth higher, fetal demise was also higher, and even admissions to an NICU was also higher. Now, Chinmay, what are the potential mechanisms leading to a short femur due to placental dysfunction? What could be the reason that we know why all about other things? Why should a short femur become short because of placental dysfunction?
So, sir, when there is placental dysfunction, the fetus chooses to ration its own blood supply. So it will preferentially give more blood supply to vital organs, say like brain, and it will reduce the blood supply to non-vital organs like abdomen and like the femur. In isolated short femur, because of placental insufficiency, we also find that the growth factors like fibroblast growth factor, placental growth factors are lesser, and placental destructive hormones like S-plate are increasing. So this hypoxia preferentially shunts the blood to the brain and thus stunts the extremities.
Yeah, so these are both the possible reasons that could be considered as the cause why you could get an isolated short femur in FGR. Now, so what isolated short femur in the second trimester, of course, is not used in the definition of FGR, but we know that it has a significant association with FGR. Hence, it's a marker for FGR, especially if it is associated with an increased mean uterine artery PI 98 to the 95th centile or reduced PAPA. That is again one association that you can get. And hence, whenever in the second trimester, you find that there is an isolated short femur and you have ruled out all other causes, you need to have serial scans to assess interval growth, and that actually is eventually going to because these are the ones which have a potential of developing fetal growth restriction. So these are the fetuses, we just don't leave them and tell them to come in the third trimester. We would probably have an early growth scan with Doppler and then, based on that, move ahead. So, we're all talking about fetal growth restriction. Dr. Girija Wag, with your years of experience in clinical obstetrics, how seriously should we take in the Indian context? Can you hear me, ma'am?
Yes, I can hear you. Can you hear me?
Yes, ma'am.
Yeah. So first and foremost, congratulations for a wonderful CME. We have been really enjoying it. Now, as far as the question is concerned, fetal growth restriction is largely neglected in the Indian scenario would be a point-blank statement that I would want to make at the outset, for the simple reason that currently, especially all walks of life of women, they are suffering from huge kind of nutritional deprivation at the time when the implantation and placentation is occurring. And this is either by ignorance or maybe either by abnormal responses to pregnancy. And therefore, if you see that current challenge that we are facing in obstetrics is also early onset FGR. And when we are looking at markers like the short femur much earlier with wonderful sonography estimations, we should definitely look at that point in time itself while we are looking at other problems. What are the nutritional issues that are associated? Because today there have been quite a few publications and experiences where we realize that such modifications go a long way in trying to improvise these outcomes. So as I mentioned, first and foremost, many a times we find that even the growth restriction, the growth study is not done appropriately. Many times the patient is put on to a 28 weeks ko aa jao. That's not fair. every time, even at 19 weeks when we are doing the TIFA scan, we are duty bound to look at the biometric parameters of the patient properly and then take a call as to where am I going to put her in. Now, if you don't have an access to good care, we can do a fundogram, and that has been now completely professed by everybody, and it has been proved beyond doubt that from 24 weeks onwards, you must start doing these growth scans. And if you have any of these anomalies seen and shown to us by the radiologist, or you yourself have seen as a fetal medicine or a gynecologist, then it's important that we have a very close surveillance for these patients, because that's only going to help us.
Thank you, madam. And on this slide, you can see the prevalence. If you look at it, severe fetal growth restriction. See, we talk so much about the trisomies and all these things that we've been concentrating on since last few years. But then FGR, fortunately, in the last 2 years, SFM has taken up this FGR, and you are finding so much of lectures which are taking place on FGR. Otherwise, FGR used to be one small talk in a complete conference on fetal medicine. In a 3-day conference, there used to be something fag end of the day where someone used to come on speak on FGR, and we need to take it very, very seriously. 26% of Indian babies are small. Now, Dr. Sandeep Kadam.
Yes, sir.
Because we always talk about how to make a diagnosis and all, because we normally do not have a neonatologist on the panel, but because you are there today, I would want our audience to know what are the immediate postnatal and long-term abnormal outcomes in FGR babies.
Firstly, I take this opportunity to thank the Society of Fetal Medicine for inviting me on this panel. A very relevant problem that we see acute, that is the short-term and long-term problems associated with FGR. Since we have a fetal growth restriction, obviously the first and foremost, these babies may be delivered early and they may be associated with prematurity. And since these babies are preterm and they may be small, there is a double jeopardy. Apart from prematurity and babies being small, there obviously is a risk which is associated with a very high risk of neonatal mortality, perinatal asphyxia. There's a very high risk of RDS. Now, we used to think that RDS is protected if they are growth restricted or they are stressed in utero. However, the current data does suggest that RDS is significantly increased in this group of babies, and they may be associated with higher morbidities, and they may be associated with higher complications. They may be associated with higher risk of necrotizing enterocolitis. There is a higher risk of polycythemia, hyperviscosity, thrombocytopenia. And nevertheless, there is also a little bit of immune dysregulation, inflammation, and also since these babies are small and vulnerable for infections. And most important, there may be metabolic problems like hypoglycemia, which may be associated with long-term problems. There may be associated with cardiac dysfunctions, myocardial dysfunctions, because the myocardial fibers are not very well developed. So they may be more at risk of developing shock in the immediate phase. And the brain is not developed well if it's an early FGR. So there is less number of neurons, less myelination, abnormal brain development, and which may be associated with long-term sequelae. So this is as regards the short-term outcomes. So there is high risk of neonatal mortality and morbidities, as we have discussed in the previous few minutes. Long-term problems which are associated with these babies are not only associated with abnormalities which are associated with the development of brain, but they are also associated with lungs and the kidneys and the growth. So what are the problems that one would see? They are associated with a very high risk of neurodevelopmental impairment. In fact, if you look at their development, the intelligent quotient, the cognitive functions, they may be associated with hyperactivity, dyslexias, autism, ADHDs. They may be associated with metabolic syndromes. Now, what we mean by metabolic syndrome is that these babies who are born small, if they are given aggressive nutrition and they suddenly catch up a lot of weight, they may be associated with insulin resistance syndrome, and they may develop diabetes, hyperlipidemia, myocardial infarction, and hypertension. So these are basically developmental origin of fetal diseases which are been described by Barker's hypothesis. And last but not the least, since the babies are born with small lungs and small kidneys, they may be associated with chronic lung disease or bronchopulmonary dysplasias and hypertension, because the kidneys are small, the nephrons numbers are less. So one needs to monitor these babies for adult onset, early onset hypertension, and they may be more vulnerable for asthma and bronchopulmonary dysplasias. So the story actually starts with short-term problems and it goes on as the baby unfolds. So we need to keep all follow-up of these babies who are born FGR.
Dr. Sandeep, if we eventually manage to get this baby out at the right time, that is neither too premature nor too hypoxic, will we be able to, yeah, we would definitely be able to reduce the immediate postnatal mortality and morbidity. But does it also then reduce the incidence of long-term problems in these babies?
Absolutely, sir. If we reduce the, see, basically if their baby is not growing well in utero, it is always good to deliver them early and give adequate nutrition in the immediate neonatal period. So that in turn would help the brain and the lungs and the other organs to grow better rather than suffering from intrauterine growth restrictions. So obviously there's always a risk of dying if they are born early versus not growing in utero and having long-term complications. So we need to have the right moment. If the babies are not growing well in utero, might as well deliver. And that again, the timing will depend on the NICU statistics and the comfort of the obstetrician and the neonatologist.
Thank you, Dr. Sandeep. And so when
Can I add something, sir, here? Can I add something?
Yes, ma'am, please.
See, first and foremost, the moment we get such a report, now, even if an isolated short femur, we must also put the patient under screening and surveillance because she would eventually develop preeclampsia or gestosis. That's a high possibility, so that's a signal for us. Because blood pressure may be still normal, but the baby is showing growth restriction, so we should do this reverse engineering. The second thing is, at this point in time, magnesium sulfate given for 24 hours and antenatal steroids will definitely improvise their outcome if we are planning to deliver them. And that has to be asserted. Currently, there is evidence which is speaking only about neuroprotection. But looking at the magnesium sulfate effectivity, it can also help in improvising placental perfusion and probably improvising the baby's outcome because of that. So this requires definitely a very close attention for these people.
Yeah, thank you, ma'am. Thank you. So we have this, we say it's a small fetus, which could be an SGA and which could be an FGR. Now, if it's, SGA is very easy to define because it's actually a statistical deviation. So any fetus, WHO has also said, whose estimated fetal weight is less than 10 centile is SGA, and hence it's easy to define. But is every SGA fetus FGR? The answer is a big no, because all small fetuses are not fetal growth restricted. And if you look at it, 70% of small fetuses are actually normal small fetuses. 10% could be because of fetal causes and all those things that we have discussed, even the chromosomal and hormonal, structural and infections. 20% are the ones which are actually because of uteroplacental insufficiency. So basically, so how do you define FGR? Is it that a fetus with an estimated fetal weight less than 10 centile, is that FGR? How would you define fetal growth restriction as such? Dr. Girija. I think we've lost her. Probably she's driving.
Okay, do you hear me?
Yes,
yeah.
Yes, ma'am.
So basically, if there is a deviation of the growth is one, but disparity of growth also becomes a sign of fetal growth restriction. So deviation can be an SGA, but if there is disparity, we must consider maybe it's a FGR, and usually comparing it with Dopplers would help us in identifying that this is an FGR. So it's actually important to not only look at the comparison between the weight or the simple biometrics, but even disparity like asymmetry also would matter, and therefore taking up a proper biometric evaluation helps us in identifying that it is an FGR.
So now the consensus definition of fetal growth restriction is that an estimated fetal weight less than 10 centile on ultrasound, but that because of a pathologic process has not attained its biologically determined growth potential. So that is the one that is a segment that we label as fetal growth restriction. But since failure to attain growth potential is a concept which is very difficult to gauge, fetal size actually is used, as a proxy, even though we know it has all its limitations. So you can have a small fetus which is estimated fetal weight less than 10 centile because of the primary defect, fetal causes we talked about, and then the FGR, that is a placental, I like to call it as placental fetal growth restriction, and then you have the constitutionally small SGA. Now, if you if you remove primary defect, these fetuses would fall into two groups. In one group, the outcome is bad. In another group, the outcome is good. There are no intrauterine fetal demises. One group, you find Doppler signs of adaptation. The other group, you don't find Doppler signs of adaptation. In the first group, you should not prolong the pregnancies beyond 37, 38 weeks. In the other group, you can prolong pregnancies up to term. And so the first group is FGR and the second group is SGA. So how do you actually differentiate? So you have a fetus with the estimated fetal weight less than 10 centile, Chinmay. How would you differentiate between SGA and FGR?
So, sir, when I'm looking at a small baby, as you very correctly pointed out, it is less than 10 centile. I would like to look more closely towards the biometry, and a baby less than 3rd centile, I'll be more alarmed towards FGR. But anyhow, for a baby who is less than 10 centile, I would like to look at the vascular changes, starting from multivessel Dopplers of uterine arteries, going over to umbilical arteries. Then I would like to see if brain blood supply showing any redistribution. Furthermore, fall in MCA PI and ultimately ductal stenosis. So an FGR baby would have abnormal any of these vascular Dopplers with a small baby less than 10 centile, and a small baby, especially between 3rd and 10th centile, with normal Dopplers would probably HGA.
Yeah. So if it is less than 3rd centile, we are putting it into the first group of FGR. But if it is between 3rd and 10th centile, and if you have Doppler abnormalities, we'll put them into the first group. And if it is the Dopplers are normal, then we will call it as SGA. Okay. Now, Dr. Rahalkar, is it important to classify FGR into early onset and late onset? And what is the cutoff that we use?
Yes, sir. So actually, early and late onset FGR are actually phenotypes of the same disease. But it is very important to classify them, to differentiate between them, because they vary with respect to the time of onset, the evolution of disease, the adaptive or reactive changes that we see on Doppler evaluation, and also with the postnatal outcome. And talking about the cutoff, we consider a cutoff of 32 weeks. If the FGR occurs before 32 weeks, we call it early onset FGR. And if it is after 32 weeks, we say it is late onset FGR.
Yeah. So that is the Delphi consensus which has come over, that we need to use 32 weeks as the cutoff. So now, how do you define early onset FGR? So what are the Doppler, or what are the features? You've just, brushed it in your, how to differentiate between the two, but how do you define early onset fetal growth restriction? What are the criteria? Chinmay. We've lost you.
As Dr. Manali said, gestational age is one of the important criteria. Hello? Yeah. Can you hear me?
Yeah.
Yeah. So early onset FGR, as Dr. Manali said, would obviously gestational age dependent, but if I were given a solitary finding of a very small baby, less than 3rd centile, with abnormal umbilical artery Doppler, especially absent endostelic flow, I would say that definitely this is early onset. Also, the contributory other findings would be a smaller abdominal circumference, smaller expected fetal weight, with abnormal uterine artery Dopplers or abnormal umbilical artery PIs. So even though there is no absence, but if I have raised umbilical artery PI with small baby who is less than 10 centile, I would usually call this as early onset FGR.
Yeah. So if you have fetal weight less than 3rd centile, definitely. Have an umbilical artery which is showing an apostolic flow, definitely solitary criteria. But if you have fetal weight or AC less than 10 centile, then if you have associated uterine artery PI abnormality or an umbilical artery PI abnormality, then we will call it as early onset FGR. And then Manali, how do you define late onset FGR? What criteria do you use for late onset FGR?
Again, we have the Delphi consensus who have defined the late onset criteria also. And basically, any IUGR after 32 weeks And if we have a solitary criteria of AC or AFW less than the 3rd percentile, it is late onset FGR. But we also have contributory criteria, at least 2 out of 3 which should be positive. That is AC AFW less than the 10th percentile, or AC AFW crossing 2 quarterlies. That is a fall of more than 50th percentile in 2 consecutive scans. Or if we have a uterine artery PI which is more than the 95th centile, or a CPR which is less than the 5th centile.
Yeah, so the second point is also very, very important. It's if you find that the fetal weight is, or the AC is falling from a higher normal to a lower normal, it may still be more than 10 centile. Suppose it's at the 15th centile, but it has fallen from the 65th centile to the 10th centile. That also an important criteria to call it as late onset FGR. So, Chinmay, what is the difference between early onset and late onset FGR? In the sense, not just about the 32 weeks and all, but otherwise, why this differentiation is, how would you differentiate between the two?
So basically the pathology is slightly different. There is lots of hypoxia in early onset FGRs. And that is the reason why our management is quite different. And in early onset FGR, we find that babies are really small. There is destruction of more than half of placenta. And that is why there are abnormal umbilical artery Dopplers. Many of them, as many as half, would have gestosis or preeclampsia associated with them. However, their tolerance to hypoxia is very good. So we can keep pulling them on, especially if they're higher vascular Dopplers like MCA, cerebroplacental ratio, and ductus venosus are normal. As compared to that, late onset FGRs, these babies are not that much used to hypoxia. So there is possibility of sudden demise of these babies. And when you see late onset FGRs, you would like to be much more careful about them. We really don't understand their pathology better, and their tolerance to hypoxia is very poor. So you would be slightly more aggressive. They're well-grown babies. You would really rather take them out than putting them in.
So basically, diagnosis is a problem in late FGR. Management is simple because we are not worried about prematurity there, because they've already attained, and the fetal size not necessarily is very small, so that also makes it easy. Even the incidence of preeclampsia is much higher with early onset FGR than it is with late onset FGR. Thank you, Chinmay, for that. Now, when we come to decision making and management on when to deliver and all, Dr. Girijawag, how would you like to take these decisions based on personal experience, or would you prefer to follow some stage-based protocols?
See, we follow protocols definitely, but we individualize. It is not about personal experience, but it is the individualization of the case is very important, because we would want to correlate not only the ultrasound findings and the Dopplers, but the patient's comorbidity that is associated, plus the time that we have at hand, and also taking into account the outcomes where the patient is going to be delivered, more of the delivery, even NST, we are doing a lot in these patients to help us take decisions. And then the route of delivery, like whether it's going to be a vaginal delivery or a elective cesarean section, the choice of anesthesia, all these things come into play. Because finally, the process of delivery in these babies also has to be well monitored, as these babies are very delicate. They cannot, handle very sudden type of deliveries that we would be embarking on C-sections. C-sections, if you are going to do, they also have to be properly done and planned and executed. So therefore, this is a balanced decision. Protocols are in place, but it has to be individualized per patient.
Thank you, ma'am. We have this Barcelona stage-based management protocols,
Correct.
which actually have been I would say the biggest advantage has been that they are more easy to adapt, and that has brought some kind of a uniformity. Otherwise, what was happening, even making a diagnosis and how severe is the fetal growth restriction, how bad are the hemodynamics, used to be very, very haphazard. Mild uterofetal insufficiency and moderate placentofetal insufficiency. All these terms were actually not giving any clue to the clinical obstetrician also, what exactly are we dealing with. And because this is an app-based, things become very simple, and we Indians do love things which are, very, very simplified, and so that they can just put it on the app and see. So this is actually a very good thing. Now, what are the criteria for Barcelona staging? They talk about 4 stages, Chinmay. So what are these 4 stages, and what is the criteria for each stage?
So it basically starts from placental insufficiency and tries to diagnose fetal acidosis in its stage 4. And this classification is, as you very rightly pointed out, very useful because everybody is speaking the same language. Everybody knows where exactly and when exactly to deliver the babies. So stage 1 is usually a severe smallness, but mild placental insufficiency. So here we are looking at very small babies, less than 3rd centile. But their umbilical artery PIs are normal. They may have, they are not absent. They are only above 95th centile. And any of these criteria. So a small baby, a small falling CPR, cerebroplacental ratio, abnormal umbilical artery, abnormal MCA PI, isolated, even though the CPR is normal, or abnormal uterine artery PIs. All of these would classify as stage 1. These babies usually have mild illness and can be managed more conservatively. In stage 2, now we are looking at babies who need earlier delivery because they are having severe placental insufficiency. So here you will see that umbilical artery Dopplers are abnormal or even aortic isthmus will show reversal. So here there is absent end diastolic velocity. As against the stage 3, where now baby is getting acidotic, baby is not getting blood supply, but still there is low suspicion of acidosis. So from absent end diastolic, now we are entering the zone of reverse end diastolic flow, at least 2 readings 12 hours apart. And also we are getting ductus venosus flow, which is getting abnormal, PIs above 95th centile. However, A wave is still maintained. Again, for both these readings, ideally scan them 12 hours apart and then confirm that we are dealing with acidosis.
Yeah. So if you're able to stage them, it becomes easier because there are protocols for how you should do the surveillance also. If whatever stage it is, what is the gestational age, and based on that, the delivery decisions are taken. So stage 1, you have already shown us, and these stages we have already gone through. Now, when it comes to management of FGR, see, the whole idea is we need to make a balance between what is more risky, whether you continuing, Dr. Sandeep said, whether, should you continue intrauterine, whether that is going to be more problem, or the prematurity is the one which is going to be more problem. So this is actually a mental fight that you need to make. And because every day in utero, the fetus spends, before 28 weeks, the morbidity reduces by 2%. And every day in utero, a fetus spends before 32 weeks, the morbidity reduces by 1%. This is regards even the prematurity aspect is concerned. See, normally I explain this in the form of, all those who have heard me before, in the form of a building where you are on the building, and I will speak to that later. But here I take the floor of the building as the gestational age. I take and you see, it's like you are on a building, a 20-floor building, and the building has caught fire. The fire is coming from down. So to jump or not to jump is based on what floor you are on and how severe is the fire. And the third most important thing is the NICU, which I call as the safety net. So you have a fire brigade, which has got a safety net there. So if you're on the 20th floor, and you have a fire which has come to the 2nd floor, you're not going to jump, because anyway, if you jump, you're going to die. If you're on the 16th floor, the fire has reached the 8th floor, still I'm not going to jump. I'll climb 1 or 2 floors down. See, the building has caught fire, so I can't take an escalator. I will have to climb down. But what I will do is, after every floor, I will come and check how far the fire has come. So if the fire is still a little away, I will still like to come down. But if I'm on the 1st floor, and even if there is a smell of smoke, I will jump. Because what will happen? I'm not going to die. I'm not going to have any problem. There is a good safety net there. And this safety net is Dr. Sandeep Kadam. So that also is a very, very important aspect. And so I would like to ask Dr. Sandeep Kadam, do the clinicians involve you in the decision making for when to deliver?
Yes, sir. Our obstetricians do involve us in antenatal consult, and they do speak in terms of when to deliver, because sometimes the optimal age of survival, like for example, if you have a 32 weeker, they may not call us. But if you have a 26, 27 weeker with FGR, they obviously would ask us what are the chances of survival and whether we can speak with the relatives and counsel them antenatally. So here in gestational age plays the most important role in terms of survival, morbidity, mortality, and costing and long-term outcomes. I think that's a very important and pertinent issue when the obstetrician would ask us what is the comfort zone. And I think we would definitely look at the gestational age and give our statistics as to what is the survival rate for that gestation, each gestational age.
Thank you. Another question I want to ask you is, what is more important, the gestational age or the weight?
So it's a gestational age.
Yeah.
It's
For example, you have both these fetuses with a fetal weight of 600 grams, but one is 29 weeks, one is 32 weeks. Which is the one which you will be more worried about?
I think I would be more worried about 32 weeks, 600 grams, because this baby is going to have a lot of morbidities and long-term sequelae. A 29 weeker with 600 grams probably would be doing much better, because herein I can provide nutrition and this baby is likely to have lesser sequelae at the long-term outcomes. So survival, I think, will be dependent on gestational age, no doubt. But a preterm SGA not growing well in utero is going to have a double jeopardy. It's apart from prematurity, it's a growth restriction. So it's like adding salt to injury.
Thank you. So now, as far as the protocols, Barcelona protocols are concerned, Chinmay, as regards delivery is concerned, we have already seen the stages. So, what do the Barcelona protocols say as regards delivery, and what should be the mode of delivery? You have to unmute yourself.
Sorry. So as you have very beautifully put over there in the slide, stage 1 requires delivery at around 37 weeks. We can offer labor induction to these babies. So even though your umbilical artery PI is slightly deranged, but if endostelic flow is present, MCA PI is deranged, CPR is deranged, still labor induction is preferred mode of delivery. Remember, this is a small baby. Babies sometimes may have surprises, and you want to kind of protect her obstetric history for the future. A cesarean will increase her antepartum risk of antepartum stillbirth in the next pregnancy, and also it will increase the risk of FGR in next pregnancy. So avoid cesarean in this stage if possible. All other stages, you want to offer them cesarean because that is the best chance to the baby. So I'll go on. Yeah. So critical endpoint, as the slide suggests, is the absent or reversal of ductus venosus AFib or altered BPP. Of course, most of our centers do not have computerized CTG, so we cannot calculate short-term variability in our centers. So these two criteria which we have to go by, and that's why, although the original paper said that 32 to 34 weeks, probably for setups like us where we don't have CCTG, delivering them closer to 32 is probably more prudent than waiting till 34.
Yeah. Thank you. Thank you, Chinmay. And what about late onset FGR? Dr. Girijawat, how do you manage a case of late onset FGR?
So we can put them through the similar criteria of identifying whatever we would do for an early onset. And of course, they would be under a closer surveillance for the sonography and the NSC. As we cater to more of high-risk patients in this class of patients, we definitely put them under hospitalization sometimes for this closer surveillance, or if we can deal with them coming to the facility on a regular basis, at least an NSC, depending on the gestational age and condition, we can consider doing it maybe every 72 hours or even once or twice in a day. And then taking reports by doing Dopplers maybe every 72 hours again. So the entire same criteria would be undertaken, and accordingly we'll decide to deliver them. Usually it's not smart to pull them beyond 37 weeks at all. And most of our NICUs today are giving excellent results even by 36 weeks. So if you can, you must try and deliver them as early as possible rather than making the baby more morbid in utero and then deliver them. And consideration for a vaginal delivery would also always be considered with a continuous EFM monitoring, because that's a good practice, and as Chinmay rightly said, we must not land up making this mother more morbid, which will challenge her further future obstetric career.
Yeah. So you know the dipping CPR, the MCA PI less than 5th centile, all these are telling us this is a late onset FGR. But the decision to deliver, yes, you know, of course, if it is 37 weeks, you need to go ahead and deliver. But if it is less than that, you have to put them into very strict surveillance. See whether the CPR is dipping, how are the breathing movements, the daily movement count, all these things come into picture. And so coming down to Manali's case, so the indication to delivery in your case, Manali, you've already told us about, was that it is late onset FGR, there was a dipping CPR, and most important thing, there was a loss of fetal movement and biophysical profile which is showing up normal. I'm sorry, I'm just covering up because we have already overshot time. There one or two important things which I wanted to discuss. Dr. Sunil Kadam, do you see cases of babies born with birth weight not less than 10 centile, but have abnormal outcomes which are usually associated with FGR?
Yes, sir. I mean, we do see fetal malnutrition, and we all know that they may be associated with some sequelae where the baby was destined to be, say, 3.5, but has become 2.6. Obviously, these babies may have some problems related to soft neurological issues like ADHD, hyperactivity, autism, or dyslexias, learning difficulties. So obviously, the baby is not falling below the 10th centile, but is between the 10th and the 50th centile, associated with problems like asphyxia, hypoglycemia, polycythemia. One needs to have a follow-up of long-term outcomes and see how they're growing and how are their neurological outcomes.
Yeah, Manali, quick answer. Is fetal smallness less than estimated fetal weight less than 10 centile the absolute marker for adverse perinatal outcome? Please unmute yourself.
Yes, so definitely we do see babies with EFW less than 10 percentile to have adverse perinatal outcome, but we should also take into consideration that babies between 10 to 50th percentile can also have an adverse perinatal outcome. Like in this study which you have shown over here, sir, it's seen that the lowest mortality was at between 90 to 95th percentile, but as the percentile value go on decreasing, the mortality or the adverse perinatal outcome goes on worsening. So especially in cases of late FGR cases, we should keep that in mind, that they could be falling between the 10th or 50th percentile, and on subsequent scans, they may develop into SGA. That is, an AGA may be converted into an SGA on subsequent follow-up scans.
Yeah, so late onset FGR can be an SGA FGR or it can be an AGA FGR also, and hence, Dr. Wagh, should a Doppler be a part of all growth scans? What is your take on this?
I would vouch for it, because I would really want all my babies to be undergoing the Dopplers, because that gives me a better insight than the biometry. Because biometry may get confounded due to various reasons. It can be nutritional deficiency, it can be water retention due to some other causes, it can be even GDM, because we have a lot of diabetes or altered glucose metabolism in pregnancy currently. And therefore, I would definitely be more comfortable if I also have Doppler studies alongside.
Thank you, ma'am. And that is one very important message, is that yes, all growth scans should be accompanied with Doppler, multi-vessel Doppler. So in late onset FGR, which is AGA, the fetal weight may be, if it is the fetal weight is between 10th and the 50th centile, at least, if not all, at least in these cases, do Doppler. If the CPR is less than 5th centile or the MCA PI is less than 5th centile, put them on surveillance, and AGA at 32 weeks will become an SGA at 36 weeks, as we saw in Manali's case there, and then it should be diagnosed and managed as late onset FGR. So in a nutshell, FGR management protocol: identify a small fetus, do Doppler, distinguish between FGR and constitutionally small fetus, stage the FGR and plan surveillance, decision on when to deliver, preferably based on protocols, and early and late onset FGR represent distinct phenotypes of the same disease. Smallness in size is a predominant characteristic of early onset preterm FGR, and it may not be a factor necessarily in late onset term FGR. That is an important message here. 40% of late pregnancy IUFD is because of late onset IUGR, and that is the reason We need to adapt to this concept of late onset FDR because we want to save these babies who actually, where most of the time the cause given is unexplained why they had an IUFD late in term. And an objective protocol-based approach is validated. Ductus venosus is the cornerstone for delivery in early onset FGR. CPR is a critical index in late onset FGR. And scans at 36, 37 weeks and 30, 32 weeks are now an important part of the protocol. An isolated short femur may be an early indicator of placental dysfunction. Patients need to be counseled accordingly, and serial monitoring is recommended. Keep calm and follow protocols. That's a message I would say. Thank you very much. Thanks a lot.
Sir, can I ask you one question here?
Yes, ma'am, please.
Hello?
Yes, ma'am, please.
Hello?
Yeah.
Am I audible?
Yes, yes.
Am I audible?
Yes, ma'am, you are audible.
Hello?
Yes, you are audible.
Hello?
Yeah, we can hear you.
Hello, am I audible?
Yes, ma'am.
Because ma'am is logging through.
Yeah. We'll wait for her comments to come in later if we are still on with the program. But I think this has been a series of 3 fabulous panel discussions. I know we've overshot time a bit towards the end, but it's really been worth it. Thank you, Bimal, for taking us through that so marvelously. And back to Santosh and Chinmay for the rest of the program.
Thanks a lot, Khurana sir, Praveen sir, and Bimal sir for this excellent inaugural CME, so to say, online. And I'm sure this is just a beginning, and we will not disappoint you. And in time to come, we'll have more and more such wonderful seminars, lectures, CMEs, case discussions, and so on. We have planned a lot of academic activities, and with participation of everybody, I think Pune chapter will be a role model for all the others. And I request Khurana sir, Praveen sir, and Bimal sir that we want a big CME or a big 2-day conference for our new chapter. And I'm sure that as Khurana sir has said, he's got special attachment to Pune and he will not disappoint us and will definitely come with all his stalwart friends and colleagues and have a memorable 2-day conference. So can we look forward to it, sir?
Of course, most certainly.
We are looking forward to
Dr.
it.
Praveen and Bimal will give us a date for this.
Yeah. Thanks a lot, sir.
We are looking forward to it, Santosh.
Thank you, sir. And I really appreciate the bosses for taking out time from the busy schedules and enlightening us and literally holding our hands of all the youngsters over here and taking us through a great 3-case memorable lecture series. Thanks a lot, sir. Thank you. Is ma'am there?
Yeah. Dr. Wagh, can you hear us now?
Yeah.
Yeah.
Yes, I can hear. So I was asking, sir, currently there are a lot of reports which are coming by. Everything happens to be fine. But then somewhere around 32, 33 weeks, placental base calcification. And that calcification is really worrisome. Now, if you have a patient of GDM or she has preeclampsia, how much credentials are you supposed to give? Because the Dopplers are normal. Should we give any credence to this?
We don't give too much of credence to calcifications these days, ma'am.
Yeah, but then if it's remarkably shown and mentioned, why would then it be mentioned so much? Are there any studies which have correlated this particular thing? Because we have learned.
That's the way unfortunately, that's the way we have been brought up, in the sense every radiology department or OBGY department with an ultrasound used to have a chart on the wall which was all about grading of placenta and all.
Yeah.
So all those who have still not moved out of it would probably still give a lot of sir.
Yeah, we have enough evidence to show that placental morphology has nothing to do with placental function. And therefore, we must drop placental calcification we must drop placental grading as soon as possible and move on, because currently we're running 15 years behind time.
Yeah.
Yes.
I felt so, because sometimes we do get reports once in a while, and especially with a morbid mother, you know, we are worried. Now what to do with this baby?
To be ignored completely.
Thank you so much. Nice touching base with you. And it was a wonderful CME. I enjoyed it.
Thank you. And thank you for being so brave and talking to us from the car.
I was so tired today. I had to reach home.
Thank you for joining in. Chinmay, you're going to do the final round of thanks for all of us.
Absolutely, sir. And couldn't thank our mentors, Dr. Arun Kindre and Dr. Gupte sir, enough for accepting to mentor us. And I'm sure under their able leadership and that of our president, Dr. Sabnis, we are going to reach out to more and more institutions, postgraduate students of both the fraternities, and get more and more lateral disciplines on board with SFM, so that not only the scanning, but what matters at the end is mothers and babies' health and their development can be focused upon. I would love to thank all our esteemed panelists and the presenters for the excellent presentations. Of course, Dr. Khurana, Dr. Praveen, and Dr. Sahani sir for excellent handholding. And there's so many learning points. I'm sure right from tomorrow morning, our practice is going to change a bit. Thanks, everyone. Thanks a lot.
Thank you. Bye-bye. Good night.
Thank you. Good night.
Thank you.
Thank you. Bye-bye. Good night. See you all soon.
One most important person I completely forgot to thank is Vishal. His persistence and organized work over there, it has really helped us conduct this webinar so excellently. Thanks, Vishal, a lot.
You're welcome, sir. Thank you. Thank you so much.
Thank you. Thanks. Bye.
Good night.
Good night.